Check, check. 1, 2, 3, 4, 5. Testing. 1, 2, 3, 4, 5.
So the slides should be in. Oh, thank you very much.
So when she says 23 questions, there's actually 23 answers.
Well, same thing, right?
Right.
There's a heading, but the questions are the letters underneath it.
Good morning. We're going to go ahead and get started. Good morning and welcome, Acting Committee Chairperson, Vice Chairperson, members, and guests. I am Maria Ellis, the Executive Secretary for the Medicare Evidence Development and Coverage Advisory Committee, Medcac. The committee is here today to focus on the state of evidence on CAR T therapies, CAR T cell therapies that are approved by the Food and Drug Administration. We are seeking the Medcac's recommendations regarding collection of patient-reported outcomes in cancer clinical studies. The Medcac will specifically focus on appraisal of evidence-based pro-assessments to provide information that impacts patients, their providers, and caregivers after a CAR T cell therapy intervention for patients' cancer. The following announcement addresses conflict of interest issues associated with this meeting and is made part of the record. The conflict of interest statutes prohibit special government employees from participating in matters that could affect their or their employer's financial interests. Each member will be asked to disclose any financial conflicts of interest during their introduction. We ask, in the interest of fairness, that all persons making statements or presentations disclose if you or any member of your immediate family owns stock or have another formal financial interest in any company, including an internet or e-commerce organizations that develops, manufactures, distributes, and or markets consulting, evidence reviews or analyses, or other services related to pro-assessments or CAR T cell products. This includes direct financial investments, consulting fees, and significant institutional support. If you have not already received a disclosure statement, they are available on the table outside of the room. We ask that all presenters please adhere to their time limits. We have numerous presenters to hear from today and a very tight agenda, and therefore cannot allow extra time. There is a timer at the podium that you should follow. The light will begin flashing when there are 2 minutes remaining and then turn red when your time is up. Please note that there is a chair for the next speaker, and please proceed to that chair when it is your turn. We ask that all speakers addressing the panel please speak directly into the mic and state your name. For the record, voting members present for today's meeting are Dr. Aloysius Cujet, Dr. Joseph Chang, Dr. Diane Civic, Mr. Nafatal Franco, Dr. Melissa Cardo, Dr. Thomas Goss, Dr. Thomas James III, Dr. Joel Lehman, Dr. Carla Personato. A quorum is present and no one has been recused because of conflicts of interest. The entire panel, including non-voting members, will participate in the voting. The voting results will be made available on our website following the meeting. I ask that all panel members please speak directly into the mics. This meeting is being webcast via CMS in addition to the transcriptionist. By your attendance, you are given consent to the use and distribution of your name, likeliness, and voice during the meeting. You are also given consent to the use and distribution of any personally identifiable information that you or others may disclose about you during today's meeting. Please do not disclose personal health information. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the Advisory Committee members take heed that their conversations about the topic at hand take place in the open forum of the meeting. We are aware that members of the audience, including the media, are anxious to speak with the panel about these proceedings. However, CMS and the committee will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting topics during breaks or at lunch. Please remember to discard your trash in the trash cans located outside of this room. Guests are prohibited from taking photographs on the CMS campus. And lastly, all CMS guests attending today's Medcac meeting are only permitted in the following areas of CMS single site: the main lobby, the auditorium, the lower level lobby, and the cafeteria. Any persons found in any area other than those mentioned will be asked to leave the conference and will not be allowed back on CMS property again. And now, I would like to turn the meeting over to Ms. Tamara Sirk-Jensen.
Thank you. Good morning. One, I wanted to thank everyone for coming today. This is an important meeting for us, and thank you for the panel for surviving all of their travel hardships last night and attending. First and foremost, we are trying to get the temperature lowered in here and the humidity lowered in here. So hopefully that will happen. Like you, I am also very warm. So, so hopefully that will happen in the next half an hour to an hour. I know we're running a little bit behind time, so I am just going to cede my time. Do we go to the chairperson, or do we go? Oh, yeah, sorry. This is why she's here. Just a reminder, if you have not signed up, we have the invited public speakers. The folks that would like to speak today that are not on a list, there is a list out back. You need to sign up before 10 a.m. this morning. So please, if you would like to speak or you think you want to speak in the next hour or two, please get your name on a list out back. And then there is also a disclosure form that you also need to sign that Maria just talked about. And I will continue to remind you of that deadline, because it is a hard deadline, so that we can then incorporate that into the agenda. It is a full agenda. There are 23 voting questions. So we are going to make sure that we move through this, because we really do need to get to those voting questions, and we want to hear what the panel has to say about those voting questions. So that is why the time is so important today. So did I miss anything else? All right. With that, I'm going to cede it to the chairperson, Dr. Ross.
Hi, my name is Joe Ross. I'm a general internist on the faculty at the School of Medicine and Public Health at Yale. Thank you to everyone for joining us today. There's going to be a very exciting discussion about this new therapy that's revolutionizing clinical medicine in some respects. I have been given a lot of advice on how to coordinate this meeting, and all I can say is I will be very strict on time. It is not personal, so if I cut you off, please, please, please respect that. And so I'm trying to give everybody an opportunity to speak. There are many people who want to have their say today, and we are very much looking forward to that. Maria, is now the time where we're supposed to introduce ourselves and disclose our conflicts? Yes. Okay, so as I said, I'm Joe Ross on the faculty at Yale and School of Medicine, and I have no personal conflicts. I do want to note that my research group at Yale receives funding from Johnson & Johnson as part of clinical trial data sharing efforts, and we also receive funding from CMS and FDA for research work. It's all through Yale, and we formally receive funding from Medtronic and the Blue Cross Blue Shield Association.
Hi, I'm Al Sujay. I have no disclosures to make.
Joe Chang, Chair of Neurosurgery at University of Cincinnati, no disclosures.
Hi, Diane Civic, no disclosures, though I do work at Anthem.
Naftali Franco, no disclosures.
Melissa Garrido, no disclosures.
Tom Goss, Boston Healthcare Associates. So I'm a paid consultant, but I have not done any work in the CAR-T area.
Tom James, Senior Medical Director at Highmark Blue Cross in Pittsburgh, and I have no disclosures.
Joel Lehman, no disclosures.
Carla Bericinoto, no disclosures.
Shami Fineglass, I work for industry. We are not involved in CAR-T.
I'm Steve Gottschalk, a member of St. Jude Children's Research Hospital. I have research support from a company called Therapeutics, and I have patent applications in the CAR-T cell therapy field.
Doug Olson, patient advocate, no disclosures.
James Yang, Surgery Branch at the National Cancer Institute. The National Cancer Institute has a cooperative research agreement with Kite Gilead.
Great, and thank you for every member of the panel for being here today and for the CMS staff for helping to organize this meeting. I'm going to turn it over now for our first presentation from CMS, from Catherine Sarama.
Good morning. Many thanks to the panel in advance for your consideration and helpful discussions today around this important topic. Currently, CMS is reviewing the evidence on chimeric antigen receptor CAR T-cell therapy in response to a formal complete request for a national coverage determination. It is critical to identify the information needed for beneficiaries to make informed treatment decisions with their providers. Therefore, today we will be discussing the study, collection, and dissemination of health-related quality of life with patient-reported outcome, PRO, assessments. Specifically, the purpose of this meeting is to obtain Medcac recommendations regarding how existing PRO assessment tools should be incorporated into future clinical studies, including future clinical studies on CAR T-cell therapy, and clinical study design characteristics, study duration, and suitable study controls. To this end, CMS has provided background materials to support your assessment of the strength of evidence on 5 voting questions. The first question requests your vote on the confidence and the strength of evidence validating 7 PRO assessments that we will describe here. The patient-reported outcomes common terminology criteria for adverse events, PRO-CTCAE, is a free assessment developed in 2008 to supply meaningful data and improve understanding of symptomatic adverse events from multiple disease states, based on the hypothesis that collecting information directly from patients improves the precision and reliability of symptomatic adverse event detection. Validity was based on comparison to established scales and follow-up based on outpatient clinical visits. Completion rates were over 90%. Results showed 98% of PRO-CTCAE items were significantly associated in the expected direction with established assessments. The MD Anderson Symptom Inventory was developed in the year 2000 from established brief pain inventory and brief fatigue inventory to be specific to cancer patients. It contains 13 core symptom items and 6 interference items, with multiple formats available. It contains, in addition to validity testing, the MD-ASI and other quality of life assessments were collected for comparison at 5 event-dependent time points in treatment for multiple myeloma and non-Hodgkin lymphoma. Completion rate was 82%. Results showed symptom severity and interference scores correlated with specific treatment events and was not sensitive to demographics, diagnosis, or laboratory measures. The European Organization for Research and Treatment of Cancer Quality of Life Questionnaire, EROTC QLQC30, was developed based on the following 6 characteristics: standardization, cancer specificity, psychometric strength, practical application to cancer clinical trials, appropriate self-administration, and cross-cultural applicability. The background materials provided include a sample of the validation work of this assessment and has been recognized in meta-analysis by Controlis et al. And colleagues as the standard measure on which more recent assessments are compared. The University of Washington Quality of Life Assessment was developed specific to head and neck cancer patients based on 3 desired characteristics: that the assessment take less than 10 minutes to complete, it is simple to understand, and measures health-related quality of life longitudinally. Version 4 includes 12 domains, a single-item quality of life question, and a free text section. The background materials include 3 publications measuring the application and validation of this assessment. Results showed 42% of UW quality of life items were significantly associated in the expected direction with the EORTC QLQC30 summary score. Completion rate was 79%. The Patient-Reported Outcome Measurement Information System, PROMIS, uses item response theory and computerized adaptive testing to build on existing items in the Patient-Reported Outcome and Quality of Life Instruments database, with focus on the following 6 desired characteristics. 1, appropriate context, the instructions associated with answering the item. 2, the appropriate STEM, the part of the item that makes it unique. 3, consistent response options. 4, minimal time spent answering. 5, instrument of origin. And 6, domain-specific rather than disease-specific measurement. To this end, the modular structure can be customized and administered specific to each individual patient. The background materials provided summarize the clinical validity for 9 PROMIS measures in 5 PROMIS domains in over 1,000 patients across 6 clinical conditions. The completion rate was 95%. The electronic self-report assessment in cancer is not a single assessment, but an electronic self-report method that contains questions regarding common cancer symptoms and quality of life measures, including the EORTC QLQC30 and Patient Health Questionnaire, PHQ-9. The background materials provided summarize the impact of such methods, where ERSAC score seemed to communicate patient health-related quality of life and reduce symptom distress with additional engagement that did not increase time during an outpatient clinic visit. Lastly, the Functional Living Index in Cancer was validated in a study by Schipper and colleagues as compared to Karnofsky, Beck Depression, Spielberger State and Trait Anxiety, and Katz Activities of Daily Living, as well as the General Health Questionnaire and McGill-Melzack Pain Index. The assessment was designed to assess the overall functional state of the patient with the following desired characteristics. 1, cancer specificity. 2, functional orientation. 3, patient self-administration. 4, high compliance. 5, reproducibility. 6, sensitivity to range of clinical practice and intensity of therapeutic intervention. 7, face, content, construct, and concurrent validity and reliability. Question 2 asks for the consideration of evidence on the following desired characteristics of a PRO assessment: breadth of measures in emotional, social, and physical well-being, quick throughput to apply to clinical study, transferable to community practice settings, measures that are not sensitive to differences in age, line of therapy, comorbidities, and that are generalizable to study of combinations of therapies, used in a net benefit analysis based on symptom burden and well-being. Additional sources of consideration include the Alliance for Clinical Trials in Oncology and other partners' recommendations for geriatric oncology research, recognizing that elderly patients are less willing to compromise on health-related quality of life and prefer to maintain function and independence during cancer treatment and management, according to these authors. We also ask for your discussion of 2 following questions regarding patient-reported outcome assessments and other desired characteristics. Question 3 asks for your consideration of an appropriate measurement period for a valid PRO assessment. Question 4 asks for your consideration of an appropriate measurement duration for a valid PRO assessment. Question 5 asks for your consideration of an appropriate control population for a valid PRO measurement. Thank you.
Thank you, Dr. Zarama. Our next speaker is Dr. William Go, the Vice President of Clinical Development at Kite.
Hi, my name is William Go. I'm the Vice President of Clinical Development at Kite, now a Gilead company. First, want to take the time to thank the committee for the invite me to speak at this, as well as to introduce chimeric antigen receptors and the discussions in terms of patient-reported outcomes. My background is I'm a PhD in T cells, and I'm a hematology oncologist, BMT, by training. So Kite, a Gilead company, is committed to the research and committed to discovering and developing a novel T-cell immunotherapy for patients with unmet need, especially in the cancer space. And we are committed and we are applauded CMS and FDA on patient-reported outcomes and recognize the importance of incorporating PROs in our own drug development process and in the overall assessment. While Kite recognizes the importance of PROs and the measurement of clinical trials, the PRO CAR-T science, where these instruments are most appropriate for CAR-T, remains still to be determined and still is evolving and is still quite early in the development. Today, I want to first introduce the CAR-T therapy of Yescarta, as well as the transformative technology of CAR-T, which has shown huge benefit for patients who have exhausted all therapies in large cell lymphoma and have not have any other options in standard of care therapy. So I know this is a busy slide, and I know we have limited time. And so what we'll do is first talk about what chimeric antigen receptors are. Chimeric antigen receptors are where you take a patient's own T cell in an autologous setting and reprogram them to express a chimeric antigen receptor where it is an antibody specific to the target antigen, in this case CD19, as well as then co-stimulatory domains and also signal 1 and 2, in this case CD3 zeta, as well as CD28. This was recently FDA approved in October 2017, and these are in patients that we studied in refractory large B-cell lymphoma. These are patients that usually have less than 6 months left to live, and in cases where I would be having hospice discussions with these patients. This is intended to be a one-time infusion and at certified healthcare facilities who have BMT cell therapy experience. So this turnaround process of a patient's own truly personalized medicine is approximately 17 days from door to door. And these patients really have very limited time in their disease state in terms of their outcomes and their overall survival. So any delay in this process from evaluating the patient, collecting their apheresis, their T cells, to engineering their T cells, to then returning them, conditioning chemotherapy and infusion, and then ultimate recovery is very key. Every day matters for these patients. And we are also in the post-approval commitment to the FDA, as well as working with others, which we'll talk about in terms of registries and future investigations of PROs. For the sake of time, I won't go through the study design, but just again, this has been published in the New England Journal of Medicine. High level, we only studied patients with chemo-refractory large B-cell lymphoma. Again, in the Scholar 1 retrospective global analysis, these patients only have approximately 6 months to live, with only a 7% complete response rate, as well as a 26 overall response rate. As you can see in the updated analysis to the right, that with a median follow-up time of 15.4 months, with everyone having an opportunity to have 1 year of long-term follow-up, the best overall response in this case, after 1 dose of cellular immunotherapy of CAR-T of axicabtagene and selalucil, was 82% with a complete remission, meaning no evidence of cancer throughout the trial, at one point at 58%. At the time of the data cutoff, 42% of the patients still had ongoing durable remission, with 40% having complete remission. This data is unprecedented, especially in this patient population. And what, again, wanted to highlight is that in this kind of refractory patient population, that this benefit risk has been very reported as positive, and this is why this is the basis of our full approval, regular approval with the FDA. Of course, in oncology, as you know, with the boxed warning, we have 2 predominantly boxed warnings, which is very consistent across the CAR-T space, as well as other T-cell targeted spaces, which is both cytokine release syndrome and neurologic events. Cytokine release syndrome is pretty much on target, which we expected, because we are re-engineering someone's own immune system to fight their cancer. And what we can see that even though that their grade 3 and higher events are clearly significant, that this is generally reversible and generally self-limiting. The median time of hospitalization in our trial was approximately 14 days. And then we already reported at scientific forums that the predominant long-term side effects have really been very well managed, consistent with autologous stem cell transplant, and really focusing more on other aspects such as infectious risks, which is consistent with the B-cell aplasia that you do see in CAR-T. Again, though, this is truly different compared to what you see typically in the end stage of large cell lymphoma. Now to the Medicare population. As you all know, the median age of diagnosis of large cell lymphoma is 58. And so therefore, you would expect to see a fair amount of patients over the age or equal to 65. In our pivotal study, we've had 25% of them were age 65 or older. What is remarkable, which is very different than auto and allogeneic stem cell transplant, we did not put any age limit on our trial or any of our trials. In fact, we just really focus on their performance status of ECOG PS 0 or 1. But you can see that we actually treated on trial up to 76 years old, and currently, even in the commercial setting, we had patients up into their 80s. What you can see here is that the observed overall response rates are very similar in patients greater than 65 years of age compared to the overall ZUMA-1 population. Specifically, objective response rate was 89% versus 82% in the greater than 65 years old. The complete response rate was 70% versus 58%. And the most important part, the durable remission rate, was 48% versus 42%. Interestingly, compared with the patients for safety, the patients greater than or equal to 65 had a lower incidence of SAEs and a lower incidence of grade 3 or higher infections. However, a higher incidence of grade 3 or higher neurologic events, as you can see here. The higher incidence of neurologic events in subjects greater than or equal to 65 of age was driven by events that would be expected to more frequently afflict the greater than 65-year-old patient population in general, such as delirium, agitation, and disturbance in attention. So now we're pivoting to what we were really asked for in terms of the committee. And what I wanted to highlight is that in a post-marketing commitment setting to the FDA, Kite Gilead is committed to be for patient safety and following patients after treatment and agreed to this extensive post-marketing registry. As a former transplanter myself and our CIBMTR colleagues in the room, we felt that CIBMTR is the right group and forum to do this registry study. Just to take a step back for people who are not aware, in America we have the American Society of BMT. With the American Society of BMT, we have other organizations that support this, as well as FACT accreditation for cellular therapy, as well as the Center for International Blood and Marrow Transplant Research, or CIBMTR. The registry objectives are quite clear. You can see that we're really looking to make sure that we, in terms of long-term safeties, especially around these cellular therapy products, and this registry may include data from other countries as well and is modular. And there is a steering committee to oversee the registry, and the steering committee is made up of representatives of key certified sites, opinion leaders and experts in the field, as well as us, Kite, and other and manufacturers, as the manufacturer.
Dr. Go, I just want you have 5 minutes more.
Got 2 slides left, or 3 slides left. I don't want to go into the data elements. Because of the 5 minutes left, I'm not going to go to the data elements here, but I just wanted to show you that this is robust. We just wanted this to show you that this is clearly robust, and then we thought about everything, and this has been in discussions with the FDA as well as other PRO experts, as well as other people in the field. Okay, so where are we with the registry? The registry has been enrolling patients as early as March of 2018. All 61 certified sites for Yes Carter are also registered as CIBMTR centers. As of July 6, 2018, you can see that 220 cell orders shipped since the registry enrollment and 82 Yes Carter recipients reporting the registry. You could probably see what's that delay. This is pretty standard as a former transplanter, that because of the data resources and the man-woman power resources to enter the data, that you usually do this either in a monthly or quarterly fashion. So this is actually expected based on that period of time. So we are clearly looking to make sure that we don't have any substantial missing data and to ensure that the enrollment is going to be clear and expected to be at 90% based on previous registry experience. We are using PROs in our Zuma trials right now. Again, PROs are highly variable, and they may be specific to disease state or designed to measure specific AEs. We are doing this in Zuma 1 in single arm of cohorts 3 and 4, but more importantly, we're doing this in Zuma 7, our randomized phase 3 control trial. We feel at Kite Gilead that PROs are best served and best interpreted in a prospective, randomized phase 3 setting, especially globally. And this is the first, to my knowledge, the largest randomized global phase 3 study in terms of CAR T, and where we're looking at axi-cel in terms of in second line compared to the standard of care in second line. Right now, the FDA approval is after 2 systemic lines of therapy. This is after 1 systemic line of therapy, and we're building in PROs prospectively. So as my final slide, the Kite experience with PROs to date. Kite generally uses PROs. However, again, we feel very strongly that it's best served in a randomized phase 3 setting. As several CAR T randomized cell trials are underway, with different PROs selected for further data collection and randomized control trials is warranted to consider the best instrument selection or modification and appropriate timing of assessments, which are key. As PRO instruments and their applicability, including scientific rigor, are still evolving, the context of CAR T treatments, we feel PROs are not quite ready for real-world coverage decisions at this time. Therapies like Yescarta are transformative and considered one time, and that have huge clinical benefit for patients with limited treatment options. These patients have advanced disease and dismal survival times, and without access to CAR T therapy would be detrimental for patients. Kite is dedicated with continuing follow-up of Yescarta patients and therefore have an extensive multi-year post-marketing registry as well as a strategy of examining PROs prospectively. PROs are a valuable tool, and Kite is committed to their study and their value in cancer care. However, we do not believe PRO data collection should be linked to coverage or these transformative therapies at this time. However, we welcome the opportunity to partner with CMS as well as other experts in the field and key stakeholders to explore these topics further. Thank you very much for your time.
Thank you, Dr. Go. Our next speaker is Dr. Ilya Ferrucci from US Oncology, Novartis.
Thank you, Dr. Ross. Okay, there are the slides. It is my distinct pleasure to be here today to speak to this Medcac Committee on behalf of Novartis, in particular in the context of these groundbreaking, innovative CAR therapies that are changing the course of treatment for patients who have exhausted all other options. I'm very grateful to be here to continue this discussion and to ensure patient access. Before getting to the topic at hand, I would like to share that a bit of my background with the Medcac Committee. I'm a paid employee of Novartis, and I do hold an interest in the company. In terms of my training, I did receive PhD training at McMaster University in health research methodology with a specialization in health technology assessment, and I've worked in the pharmaceutical industry for 5 years. My research experience spans a total of 7 years in both the academic and industry settings. During my time in industry, I've supported the inclusion of the patient's voice in the drug development process through the development, validation, and interpretation of patient-reported outcomes in ophthalmology, dermatology, aesthetics, women's health, and oncology. For the benefit of today's panel, I would like to share Novartis's experience with patient-reported outcomes in clinical studies of Kymriah, the first approved CAR T therapy. This may benefit CMS and the panel as it considers whether patient-reported outcomes should be included in future clinical studies of CAR clinical research. A patient-reported outcome consists of any measurement based on a report coming directly from the patient regarding their health or their condition without interpretation, any interpretation of that report by a clinician or anyone else. Novartis collected such PRO data during its registration studies of Kymriah in leukemia and lymphoma to specifically measure changes in patient-reported disease burden and its impact on quality of life. This information was in turn provided to regulators to inform the risk-benefit analysis of Kymriah as an investigational medicine. However, with the approval of Kymriah for both leukemia and lymphoma, we are concerned about the burden of additional PRO data collection on both patients and providers beyond the context of registration studies for these very sick patients. Kymriah is the first approved CAR T therapy, having received 2 FDA approvals in the past 12 months. The first was for the treatment of patients up to 25 years of age with B-cell precursor acute lymphoblastic leukemia that is refractory or relapsed after second-line therapy. So again, this is a patient population who have exhausted all standard of care treatment options. Our second approval was for adult patients with second-line or later relapsed refractory large B-cell lymphoma, including diffuse large B-cell lymphoma, high-grade B-cell lymphoma, and diffuse large B-cell lymphoma resulting or arising from follicular lymphoma. Kymriah is available for both approved indications through a restricted risk evaluation and mitigation strategy program via a network of certified treatment centers, and it may be administered on an outpatient or inpatient basis. For both approved indications, these relapsed refractory patients have a very poor prognosis with prior therapeutic options. They also experience substantial disease burden, which motivated us to incorporate patient-reported outcomes to measure changes in that disease burden and quality of life from the patient's perspective in our registration studies. For the purposes of today's Medcac, I will focus on our PRO experience in that diffuse large B-cell lymphoma population, which bears the greatest relevance for Medicare patients. Standard of care in second-line diffuse large B-cell lymphoma consists of high-dose chemotherapy with autologous stem cell transplant, but as many as 3/4 of those patients may not be eligible to undergo the transplant procedure for various reasons. While salvage chemotherapy could be an option for these patients, response rates remain low and survival is quite short. Taken together, the prognosis is grim for these patients who are relapsed or refractory after first-line treatment. Approximately 21% will survive to 18 months following their relapse. I'll skip ahead to our DLBCL slides here. The safety and efficacy of Kymriah in DLBCL was established in the Juliet study, a single-arm multinational registration trial that enrolled patients from the US and 9 other countries in North America, Europe, and Asia Pacific. Efficacy was measured as best overall response rate comprised of both complete and partial response. With a median follow-up of 14 months, Kymriah demonstrated a best overall response rate of 52%. The most common adverse events in Juliet included some of those that are well known, and the previous speaker did address cytokine release syndrome and neurologic events, but also prolonged cytopenia, infections, and febrile neutropenia. In our clinical study, most adverse events were resolved within 8 weeks of treatment. Now to patient-reported outcomes. With the objective to measure disease burden and quality of life, the functional assessment of cancer therapy for lymphoma, or FACT-LYM, was administered in the Juliet study. We selected this specifically because it's a disease-specific PRO measure that was developed and validated specifically for use in adult lymphoma patients. This is of particular importance to Novartis as we sought to collect information from patients using measures that have established validity and reliability for the specific disease context being studied, and required a measure that had been translated and validated in several different languages given the multinational nature of our study. The FACT-LIM includes 4 cancer subscales from the FACT-G measure, which is a general cancer measure. And that includes physical, social, emotional, and functional well-being over the past 7 days. And it also includes a lymphoma-specific subscale containing items that are particularly relevant for lymphoma patients and the symptoms that they experience. We administered the FACT-LIM at screening and at follow-up months 3, 6, 12, 18, and 24. This administration schedule was designed specifically with the intent to measure changes in disease burden, not exactly the burden of treatment, while minimizing the patient's questionnaire burden. Here are some of our results. As compared to baseline scores, we observed clinically meaningful improvements in patient-reported quality of life at months 3 and 6 of follow-up among those patients achieving a partial or complete response. These improvements met thresholds of clinical importance despite the initial toxicity experienced after a one-time treatment. Importantly, this PRO data proved useful in corroborating the clinical data that we also observed, indicating that clinical improvements were associated with corresponding improvements in quality of life for these patients. It's also worth noting here that data missingness was highest among non-responders, as these patients left the clinical trial for additional treatment elsewhere, and this is very much reflective of real-world practice as well. This created challenges for interpreting PRO data and should be a key consideration for future clinical studies of CART and its alternatives. Follow-up does continue for this Juliet study population, with data for months 12, 18, and 24 forthcoming. We also use the short form 36 questionnaire to measure health-related quality of life. You may be more familiar with this. It is among the most widely used questionnaires owing to its more general nature, which facilitates comparison to other diseases. This was also requested by regulators outside of the United States. Again, here we observed clinically meaningful improvements on the short form 36 across general health, bodily pain, vitality, physical functioning, role emotional, role physical, and social functioning subscales, with only the mental health subscale not showing a clinically meaningful improvement over baseline. Again, these findings did corroborate improvements in clinical endpoints, as well as improvements noted in the FACT-LIM. A bit about PROs and incorporating them in your research. To support the collection and interpretation of PRO data, there was significant effort and investment made to prepare for PRO administration, collection of PRO data, and reporting of such data. I won't go into every point on this slide, it is extensive, but I wanted to be able to share this with the audience for consideration. The extensive training, infrastructure, and analytic expertise needed to support the meaningful inclusion of PROs in clinical research bears important consideration for future clinical studies that this Medcac committee may be considering. Many of these needs, the infrastructure and whatnot, do exist in the context of clinical trials for registration purposes, but outside of this setting may require additional investment to ensure appropriate instrument selection, administration, and interpretation. In the context of CAR-T studies, that would necessarily impact both the sites where CAR-T is administered as well as any subsequent location that the patient may go to for their follow-up care and for the comparators, which may not be at one of these FACT-accredited sites. So therefore, we do urge caution to this Medcac panel in its mission to identify a PRO measure for future CART studies. Although CART therapies are currently approved for relapsed refractory diffuse large B-cell lymphoma, applications may include other relapsed refractory patient populations in the near future, including adult acute lymphoblastic leukemia, chronic lymphocytic leukemia, multiple myeloma, and follicular lymphoma in the future. Symptoms, adverse events, and burden may vary across these diseases, which vary also in their acute versus chronic nature. and that may necessitate the use of different measures depending on research objectives. This is just one of the important contextual factors that makes it challenging to advise the panel on a single PRO measure for all future studies of CART in advanced cancers. Moreover, it is important to clearly define research objectives when considering whether to collect patient-reported outcomes data, particularly given the burden associated with advanced disease experienced by the patients that are likely to receive this therapy. Despite the significant support of a registration study and the infrastructure therein, we experienced challenges collecting PRO data, which resulted in missingness and risks to data quality and interpretation. This could very well be amplified in larger trials or in real-world practice. In closing, I would like to thank the committee for the opportunity to share our experiences, and I look forward to addressing questions later in this meeting.
Thank you, Dr. Ferrucci. Our next speaker is Dr. Paul Klutz, the Associate Director of Patient Outcomes at the Oncology Center of Excellence at the FDA.
So good morning, my name is Paul Klutz, and as was mentioned, I'm a medical oncologist currently serving in the U.S. Food and Drug Administration, serving as an associate director in the newly formed Oncology Center of Excellence, and I've been leading efforts to formulate a patient-focused drug development effort for oncology that will cross the centers with the advent of the 21st Century Cures Act. I have no financial relationships to disclose. I'll be using several examples of PRO instruments within my slides, mainly to illustrate important characteristics that we think about for the use of PRO data for regulatory review. These are examples and not blanket endorsements of one instrument over another, and we definitely encourage sponsors to come and talk to us about which type of tool they want to put in their trial. So I think it's important, and we'll hear about this probably more today, that I'm only one stakeholder, or I represent only one stakeholder. As you can see, data from controlled clinical trials are going to be used for many different stakeholders, and especially when there's only one clinical trial usually at the time of approval in cancer. And so part of the challenge in designing a PRO strategy for industry is that they need to meet the needs of all these different stakeholders who may have different needs. And this is why the FDA Oncology Group and the work that I've led has included domestic and international payers, as well as international regulators, industry, and importantly, patients in our efforts to try to standardize the field. So the outline for my presentation is as follows. I'll introduce some definitions because this is a unique research space that has its own language, and I want to make sure we're all on the same page. We'll talk about clinical outcomes. I'll talk about an effort we've led to provide some core concepts to measure as an expectation to create some standardization. I'll go on and talk about measurement tools. How do we measure these concepts, and what do we use for characteristics for patient-reported outcome tools? And then I'll talk about, importantly, endpoints. What questions are we asking? Because if we don't know what questions we're asking, we can't formulate the correct endpoint to answer that hypothesis. So on this slide, I'll start to introduce some common terminology. So a concept is any aspect of an individual's clinical, biologic, physical, or functional state or experience. So it's the broadest of things that you start with in your trial. A concept can be clinical, like pain, function, or survival, or it can be non-clinical, like a biologic, pharmacodynamic biomarker, or a PSA. When your concept is something that describes how someone feels or functions or survives, it's called a clinical outcome, and this has important regulatory implications because we provide regular approval based on clinical outcomes, survival, or how a patient feels or functions. And if we're not looking at survival, we're looking at feels and functions, we need to use a clinical outcome assessment, and one of these types of assessments is a patient-reported outcome, which we'll talk about today. Finally, a test or tool or an instrument is actually the assay that you use to measure your clinical outcome, and in the case of patient-reported outcomes, this is the questionnaire and its scoring manual. And an endpoint is the most precisely defined variable that you're really talking about, intended to reflect an outcome of interest that's statistically analyzed if you want to make a claim of treatment benefit to address a particular research question. And all these definitions are available at this link that I provided, which was an NIH and FDA collaboration to create some standard terminology called the BEST glossary. So just to walk down this terminology example, you may be interested in pain in your clinical trial. The concept of interest is pain. Pain is a measurement of how someone feels, so it's a clinical outcome. A clinical outcome assessment that measures pain is considered to be a patient-reported outcome because patients are usually in the best position to quantify a non-observable symptom. The PRO instrument you might want to use could be the brief pain inventory. It's got 15 questions, but you're not going to use the whole thing. You might only use one question as your endpoint, and so your endpoint could be a 2-point decrease in the third question, worst severity in 24 hours, of this questionnaire. That's seen and confirmed by a second result 2 weeks later with no increase in analgesic use. So I only put this up to show you how specific the endpoint can be in order to really create a well-defined and reliable assessment. So as we've seen, a clinical outcome is a measurement of how someone feels, functions, or survives. I've said overall survival is, or I should say overall survival is a common endpoint we use, and if you're not measuring that, you're measuring symptoms or function. These are the 4 types of categories of clinical outcome assessments that we can use, and they really have everything to do with the source of the data. Where's the data coming from? A clinician-reported outcomes comes from the clinician. After a history and physical, for instance, safety is reported in clinical trials as a clinician-reported outcomes typically. Observation-reported outcomes are, say, a parent reporting on an infant on an observable sign. Performance outcomes is like a 6-minute walk test where you're asking a patient to perform something, and then patient-reported outcomes are, as was just described, a questionnaire and it's information coming directly from the patient without interpretation or change by a clinician or anyone else. So when I ask you what's your pain and you say it's an 8 out of 10, that's the answer. It's an 8, and that's how we use it for our endpoint. Increasingly and interestingly, there's a 5th type of data stream that we're starting to see more often, and this is mobile technology tools like sensors and wearables. And I think this holds promise to complement patient-reported outcomes, especially with respect to physical function. It's certainly an area of evolving regulatory and scientific interest, and we're working in several collaborations to try to understand this better. My personal view on wearables is that for concepts like physical function, I think it can complement patient-reported outcomes data, and I think both used together can provide internal validation and be quite powerful. So patient-reported outcomes has been in trials for a long time. We have instruments that are 30 years old. Why now? Why is there so much enthusiasm for patient-reported outcomes or clinical outcomes in general? Well, number one, there's recent legislation that FDA has been charged to attack patient-focused drug development, to take a look at patients and see what's important to them throughout drug development. And part of what's important to them is measuring how they feel and function. So we need to try to do a better job with that, and that's what we've been doing. I think everyone realizes we're in an era of lots more options now, so we can inform our therapeutic choice better if we have more data on how patients feel and function. Technology is definitely improving our capabilities, not only to measure PRO through electronic capture that creates structured data that's easier to aggregate and easier to utilize, but also, again, with wearable devices and biosensors, creating passive data streams. And this allows you to look at patients outside of the clinic. And so you can identify probably a real stream of real-world data that we're starting to see. We're going to hear from Dr. Ethan Bosch today on his work using patient-reported outcomes to monitor symptoms and has shown some benefit to patients in the clinical setting. So I think clinical care is starting to utilize patient-reported outcomes more for communication. And again, that's probably going to become more common and provide a stream of real-world data. And finally, we've talked about PRO CTCAE as a library. These item libraries are very interesting. They're allowing us to be more flexible with our trial design, so we can select only those symptoms that are likely to occur and not be asking patients about symptoms that are not going to occur only because they're on the legacy instrument that was developed in the era of cytotoxic chemotherapy, for instance. So we talked a little bit about clinical outcome assessments. I'd like to talk a little bit about core concepts and what we've been working on to try to organize a standard approach to our work. So many things can be measured with PRO. Many things. You can look at symptoms, you can look at side effects, you can look at symptoms of disease, work life, sexual function, overall health, quality of life. You can ask many things, distress. What should be the core concepts that we focus on for our work in evaluating a therapy? Because the heterogeneity in PRO concepts that are being measured right now, and the heterogeneity in the tools that are being used to measure them, and the heterogeneity in the assessment frequencies has been very problematic for the FDA, and I think for the scientific community in general. So I think a concise set of PRO concepts can create consistency And the focus for our work in evaluating a therapy should be on isolating the therapeutic effect. We want to know what the drug is doing to the patient and their disease rather than other non-drug influences. So to illustrate this issue of isolating the therapeutic effect, we can use this figure, which is a conceptual framework of health-related quality of life, or quality of life more broadly, adapted from Wilson and colleagues in the 90s. You can see the investigational therapy is going to be given. It's the blue circle, and it's going to affect biologic and physiologic variables. It's going to have on-target and off-target effects. It's going to create symptomatic side effects, and it's going to hopefully alleviate symptoms of disease, and that net benefit or drawback is going to be associated with functional changes, which then feeds into general health perceptions, which then feeds into quality of life. And as you can see, as you walk down from the proximal symptoms to function, to health, to quality of life, there's a lot of inputs that begin to come into play that are non-drug influences. Things like motivation, psychologic factors, support, value preferences, spirituality, et cetera. And so we have at the FDA focused on proximal symptom and functional measures because we would like to isolate the effect of the investigational therapy to the extent possible. It's never going to be perfect. And so in 2016, when we were asked to review the patient-reported outcome landscape, we proposed to focus our current work on looking at symptoms of the disease symptoms, symptomatic adverse events and side effect impact, and physical function and the ability of patients to work and perform their activities. These are all key components of health-related quality of life, but not all there is to health-related quality of life. Importantly, we know that other stakeholders would like to know about health-related quality of life as well as some of these other distal domains, and we know from international payers, et cetera, that they need this. So anything that we do, we want to make sure that it's going to get the data for everyone that needs it. And so it's going to require a different way of thinking about Puros strategies. So what about the measurement tools? What can we do to measure these concepts? So a fit-for-purpose patient-reported outcome instrument for FDA purposes is appropriate for its intended use. That means that the study design, the patient population, and the therapy under study need to be appropriate. What's the baseline function of the patients? What kind of side effect profiles are we going to be seeing? Is this a TKI versus immunotherapy? Is this a cytotoxic versus a TKI? You know that there's going to be very different toxicities for each. The instrument has to validly and reliably measure the concept, and it needs to be both clinically relevant and important to patients. And both of them need to occur for them to be a good measure in a clinical trial, and they don't always align. So an example is sexual function in prostate cancer. If you have a local therapy and the patient has an intact prostate and intact sexual function, it's important to patients, and it's going to change potentially with the therapy, which is prostatectomy or radiation. On the other hand, in the metastatic setting, where patients have had their prostatectomy, are on lifelong androgen deprivation therapy, and they're very unlikely to ever regain their sexual dysfunction, while it's important to patients, it's a terrible trial measure. I could have a wildly effective drug in that setting that shows no benefit in sexual function, and you may undervalue in that setting the effective drug. Finally, I think, and importantly, we have to be able to communicate this data in the FDA label in a way that is non-misleading and accurate. And so it has to be well-defined what you're measuring. And I want to really get into well-defined a little bit because I think that's important for instrument selection for FDA purposes. Well-defined means the questions within the PRO scale ask about the concept they're measuring. For instance, the concept of physical function can be defined as a patient's assessment of their ability to carry out activities that require physical effort. And here I give two examples of well-defined physical function domains. So for PROMIS, or the PRO Measurement Information System by the NIH, there's 4 questions, all asking about varying levels of activity, and that will be rounded up into a score or a scale, and the physical function may either be better or worse, and we can label that knowing that all those questions were related to physical function. Similarly, with the EORTC, their physical function domain within the QLQC 30 has 5 questions ranging from lowest to highest function, and they're all asking about physical function. So when we label physical function as improved, it's not misleading. This is what was being asked. Another example of a well-defined scale could be the concept of disease symptoms. You may have several symptoms that you wrap up into a single score, and that symptom scale or score should be well-defined. They should all be symptoms of the disease that you're studying. This is the myelofibrosis symptom score that has 6 cardinal symptoms of myelofibrosis, and this was labeled in the FDA. So I showed you what is well-defined, what's not well-defined. In this example, I'll give a fictitious example of a fatigue score, and if you take a look at these 6 questions, which are intended to measure the concept of fatigue, is this a well-defined scale? Now, I've made this up, so this is not a real scale. So in the first 3 questions, these are asking about questions directly related to fatigue. How tired are you? How much weakness do you have? And what's your energy level? But the last 3 questions are problematic from an FDA standpoint. So what level of pain do you have, and how much numbness and tingling do you have may contribute to your fatigue? And what is your health-related quality of life may be an impact of fatigue. Obviously, high fatigue will cause low quality of life, but it's not fatigue itself. So now when you wrap that up into a fatigue score and you say fatigue was improved, it's kind of a little bit misleading, because what if it's all driven by quality of life? Or what if it's all driven by neuropathy? So then we have to break it down and try to look at the item level, and that becomes problematic for FDA. So as I mentioned before, we're only one of many stakeholders, and so whatever the strategy is for core concepts that have well-defined physical function and disease symptoms, treatment side effects, we need to be able to create a strategy where everyone gets the data that they need. So we need a thoughtful combination of existing static tools, like short-form well-defined physical function, for instance, coupled with item libraries so you can select the right symptoms for your context. And it's going to require a modular approach. And what do I mean by that? Conceptually, if you look at a modular approach, it would mean that all these functional domains of health-related quality of life can be measured separately, scored separately, and are well-defined, and you could actually create an endpoint out of any one of these boxes: cognitive function, physical function, health-related quality of life. And within that, you can have a little more fidelity and flexibility on these core proposed FDA concepts that I mentioned before, using item libraries or standalone disease symptom scores like myelofibrosis, or now there's non-small cell lung cancer SAQ that was just qualified. Examples of modular PRO instruments I wanted to give you: URTC-QLQC30 is one example of a modular design. Now, it's a 30-question health-related quality of life form, but it's not all added up and provided one score and that's it. You can see this is taken directly from the scoring manual, that each of the functional scales are scored on their own. They have symptom scales and items that are also scored on their own, and a 2-question global health-related quality of life or health score that's also scored on its own. So it's very modular, where if we wanted to look at physical function specifically and the company wanted to add that as an endpoint, a specific endpoint, we could do so, and it would be considered well-defined. Another example of a modular system that was mentioned earlier is the PROMIS system that was designed specifically to be modular, to be able for you to choose specific scales and domains and add them to your trial as you see fit. And then a third example of a tool that you could apply to a modular type of framework would be an item library, where you can select symptoms in a flexible way to specifically address trial questions. And this is the Pro-CTCAE, which is an item library we'll probably hear more about, that's specifically for symptomatic side effects. So it really looks at safety and tolerability as a clinical trial objective. So I'd like to end by looking at the big picture. We can select core concepts, we can agree on well-defined instruments, but how are you going to define your question, and what is the endpoint going to be that's going to answer that question? Again, as I mentioned, the definition of an endpoint ends in to address a particular research question. We have to come up with some standard questions that we feel PRO can help us answer. So what are some common research objectives? Well, I mean, for my purposes, we really look at safety and efficacy. So are you looking to explore safety and tolerability? You can certainly complement safety by looking at longitudinal symptomatic adverse events. You can also look at overall side effect impact, which in reviewing some slides, I think we might hear about a little later. And then with efficacy, as I described, you can do symptom scores, improvement in symptoms. You could do improvement in physical function. If you had an esophageal trial, esophageal cancer, you may want to do swallowing as a functional domain. So you got to know what your research question is. So I've proposed a background on what different kinds of outcomes are. I just want to show you what I think the important data elements could be in future cancer trials. Currently, this is really what we focus on. And this served us very well, as has been described by the CAR-T results. We look at overall survival, we look at progression-free survival, tumor measures, overall response rates, serum biomarkers, and clinician-reported outcomes like CTCAE safety data and dose modifications. And that gives us a really good sense of the drug's safety and efficacy. But we're in the era of patient-focused drug development. We can do better. Some of the things we're looking at include other clinical events that are occurring that are going to be important to patients: hospitalizations, ED visits, morbid procedures, supportive care use. We have some of this in our trial data sets, and we've begun to start asking companies to provide us with some of this data for us to further explore some of these concepts. Today, germane to this advisory committee, I also think patient-reported outcome and other clinical outcome data and potentially biomarkers and sensors can provide this patient-centered data. In my mind, if we could just focus on, start with these core concepts as the basis and make that consistent across trials, we could add things on top of that as well. But look at disease symptoms, symptomatic adverse events, overall side effect impact, and physical function and ability to perform your activities. By being clear on these core PRO concepts or clinical concepts that we can measure, we can begin to do what we've done with our other trial measures. Let's take a look at the standardization based on certain data elements. Survival, highly standardized in how we assess, analyze, and present these endpoints. Tumor progression, very highly standardized, as well as tumor shrinkage using RECIST criteria. Adverse event reporting, highly standardized using the CTCAE lexicon. Now, what we need to do better at is to take a look at these core PRO or clinical outcome assessments and begin to standardize those. What are the RECIST criteria going to be for patient-reported outcome core concepts? And that's really where we're expending a lot of energy right now. So again, at FDA Oncology, we've talked about the concept, we've talked about the instruments, and I think we have a relatively reasonable plan and path forward. We're moving now on to standard objectives, endpoints, analytics, so that we can get data standards, start to create some SAS codes to really be able to scale this, because I don't think I can overestimate the amount of resources it takes to get through some patient-reported outcome data sets that may not be super standardized, and there's no clear, specific endpoint in mind. They can be very challenging. So if we start with standard objectives and concepts and create endpoints that we can all agree upon in a couple of standard ones, I think we'll go a long way. So a couple of examples to end from going from concept to instrument to endpoint. If you're looking at disease symptoms as one of your core concepts to measure, you could use the myelofibrosis symptom assessment form as a well-defined instrument to assess those symptoms, and the endpoint could be 50% or greater reduction in symptom score by week 24, and guess what? That was exactly what was used as a key secondary endpoint, statistically tested, supporting the regular approval of ruxolitinib in the treatment of myelofibrosis. Can be done. From concept to instrument to endpoint using physical function, we haven't had many physical function applications where they used it as a key secondary endpoint, none actually as a key secondary endpoint. But if the concept of instrument interest is physical function, the instrument could be PROMIS, could be ERTC, could be any well-defined functional domain. And one possible endpoint, just throwing it out there, could be what is the physical function change from baseline at 12 months, giving you enough time to experience the toxicity, to understand what some relatively subacute toxicity chronicity will be, and whatever benefit you're getting from the drug may start to appear. Now, these lots of problems with cross-sectional analyses, picking one time point. And I want to illustrate that quickly because I think it's relevant for today. Let's take a look at a fictitious physical function over time diagram. On the y-axis, you have the physical function outcome result. You have administration of the drug at time 0, 30, 60, 90 days, and this might be what a patient's physical function does over time. The context here, which may sound familiar, is a therapy that's given once, not chronically, that has significant toxicity early, that then begins to recover, and if the patients have significant functional decline at baseline because it's a significant severe disease, may actually improve function later on as the patients recover completely. Now, if you chose your cross-sectional endpoint at 30 days, you're going to see a decrease in physical function in this example. If you choose your physical function at 90 days, you're going to see an improvement in physical function from baseline. So you could have completely different results if you select an endpoint. So in endpoint A, we're really looking at tolerability, and in endpoint B, we're really actually looking at efficacy. And that's why you need to understand your disease, your context, your endpoint definition, and really be thoughtful about your strategy. I want to also make one note that when we look at patient-reported outcomes data, it's within the context of everything about the drug, the patient, the disease, the tumor measures, the survival, everything. And it's very different contexts in certain scenarios. So if you have an adjuvant curative therapy that's given for a specific period of time, it's going to have significant toxicity, but it's a defined treatment duration and there's potential for cure. That's one type of context to put your risk-benefit decision into. And then if you have a palliative non-curative therapy, which is the vast number of examples actually in solid tumor oncology, you treat into progression, you have cumulative toxicity as you go on with treatment, and the benefit is typically limited to the time on therapy. When you progress, the therapy is no longer effective. That's a different context to think about what your results show. So in conclusion, clinical outcomes in my mind can complement, not replace, survival, tumor, and standard safety measures, and patient-reported outcomes are one type of clinical outcome. There are others. Patient-reported outcome functional scales and symptom scales that create a score out of a number of questions should be well defined so that we can allow clear communication in FDA labeling. Several patient-reported outcome measurement systems exist, and we don't need to reinvent the wheel. Some concepts are relatively agnostic to the scenario. That's why I think physical function is a nice concept to measure. It's important in CHF, it's important in COPD, it's important in metastatic cancer, it's important across a lot of different diseases, and in fact, that sort of was what the PROMISE idea was mentioning. I think, finally, it's really critical that you come to the FDA with your specific trial. I think we can help, and we would like to start providing written guidance to try to standardize some of these things, which I think will help the community a little bit in this sense. And I think it's also critical, as I mentioned, to understand the treatment context and carefully consider taking a research objective and creating an endpoint that supports that. So thank you for your time.
Thank you, Dr. Klutz. You should know that I very nearly interrupted you halfway through before I was reminded that you were given 30 minutes to speak, not 15. So I will note now that coming to the panel, Dr. Claire Snyder, a professor of medicine, oncology, and health policy and management at Johns Hopkins School of Medicine and Public Health, along with Ms. Alyssa Bantug, a manager of communication, education, and survivorship of the Johns Hopkins Breast Cancer Program, both at Johns Hopkins, and they were given 40 minutes to speak today.
Good morning. It's my pleasure to be here this morning. I'm Claire Snyder, and I'm pleased to be here with our patient advocate partner, Alyssa Bantug, to talk about some research we've done with funding from the Patient-Centered Outcomes Research Institute, looking at how to display patient-reported outcomes data so that patients and clinicians can understand what the scores mean and use them in practice. I currently and have previously received research funding from Genentech, and I receive royalties on a section I write in Up to Date on cancer survivorship. Ms. Bantug has nothing to disclose. To be clear about the purpose of our presentation today, CMS asked us to talk about our project in terms of how it involved engaging with patients and other stakeholders to develop improved presentation strategies for patient-reported outcomes. So our emphasis is on the stakeholder engagement methods that we used, as well as providing you some insights on our study results. I want to emphasize that when we looked at the different data display formats, it was agnostic to pro-questionnaire. So there's nothing that I'm going to present today that would impact one questionnaire versus another. There are 3 different contexts or applications of pro data that our study addressed. The first is individual patient monitoring. This is when a patient completes a pro questionnaire about how he or she is doing. The data is fed to the clinical team and is used to inform his or her personal care. This has been shown to improve communication, help monitor progress, and inform management. This is an example data display format for an individual patient. It shows the current score and previous scores with possibly concerning scores highlighted in yellow. Because this application is less relevant to the discussions today, I just wanted to introduce it, but we will not be focusing on it. More relevant to this group is how you display research study results. And this is just an example study from the New England Journal of Medicine looking at quality of life among prostate cancer survivors. And the results of this were translated into data appropriate for display to patients so that they can see that either external beam radiation or brachytherapy are less toxic to bladder control compared to surgery. Those same data were displayed in the actual journal publication in a much different way. The problem with all these data displays is that it can be very challenging to interpret because of the variations in pro instruments. So I think we're all familiar with the multitude of pro instruments out there. The last time I checked, there were over 800 listed in the ProQualid database. And across these instruments, there is no standardization in how they are scored, scaled, or in how the data are presented. So on some pro questionnaires, such as the SF36, which we've heard about, higher scores are always better. On other pro questionnaires, higher scores represent more of what is being measured. An example of this is the QLQC30, which we've also heard about. That means higher scores are better for function domains, but worse for symptoms. And then on some questionnaires, lower scores are always better. This is frequently the case with symptom questionnaires or something like the sickness impact profile. There's also variation in how pro instruments are scaled. Some are linearly transformed, 0 to 100, with the best and worst at the extremes, whereas others, such as PROMIS, are normed to a general population average of 50. Because of this, a score of 50 can mean entirely different things, and it can be difficult for patients and clinicians to keep track of that. And finally, there's variation in how the data are presented. We've seen examples of that this morning in terms of whether you show average scores over time or the proportion meeting a responder definition. Based on all of this variation, patients and clinicians have told us that they value pro data, they want to use it in practice, but they have difficulty understanding it. So we undertook a 3-part mixed method study, again with funding from PCORI. And in the first part of this study, we looked at current approaches for displaying pro data to find out what patients and clinicians found helpful and what they found confusing. In the second part of this study, we took the results from part 1 and partnered with patient and clinician stakeholders to develop improved presentation approaches. And in part 3, we tested those approaches. As I mentioned, we were brought here today primarily to talk about how patients and other stakeholders can be engaged in research. So it's now my pleasure to introduce Ms. Bantug, who will talk about our stakeholder engagement approaches and her role as our patient partner.
Thank you, Claire. It's a pleasure to be here today. I'm going to talk a little bit, as Claire mentioned, about our stakeholder engagement. So in a research study with 30 oncologists, almost all felt that pro data had value. However, less than half felt comfortable interpreting these results. And as Claire mentioned, there's a lack of standardization when it comes to how these measures are scored, scaled, and displayed. Research also indicates that some methods used to display this data are more easily understood than others. When we designed this study, we wanted to come up with a way to better display pro data that impact clinical practice. Our stakeholders were around and along throughout the continuum of care. We wanted to make sure that they were available to aid in better understanding and use. The stakeholders were part of our investigative team as well as an advisory board that we put together. In addition, we wanted to make sure that they were involved in study conduct. There was broad inclusion with stakeholders, as I mentioned, on the investigative team as well as the advisory board. This included doctors, nurses, physicians, caregivers, as well as being part of study subjects. This helped with the intervention and development. And finally, with how the study was implemented and disseminated, advocates were really helpful in study implementation, and they were critical in the dissemination process. So looking a little bit about how we did this, we put together a core team, an investigative team. This included patients and caregivers, pro-researchers, as well as clinicians. And as you can see here on your screen, there's a picture of me in the top corner representing a patient as well as a caregiver, a cancer patient, and taking care of my mom who is a cancer patient. On the bottom of your screen, you can see a great picture of Claire here as a pro-researcher, as well as Michael Brundage, who's a radiation oncologist in Canada and a pro-researcher who's very well versed in a lot of these pro metrics. So we had this core team. We met together weekly, the Hopkins team. We also had a qualitative researcher who was part of the team. We met weekly together and with Michael on the phone. And then we worked with an advisory board that we put together to really make sure we had broad representation. We felt like the Stakeholder Advisory Board definitely improved generalizability. It gave us direction and guided our research project. It helped with connection using various groups, including advocacy groups, journal editors, professional groups, etc. Again, this helped with us with implementation and dissemination. And here you can see a list of our stakeholders. Again, you have a list of patient advocates. We had someone representing nursing perspectives, caregivers' perspectives, clinical perspectives with nurses and researchers, journal editors, as well as pro-researchers here. So looking beyond what we did between our Stakeholder Advisory Board and our investigative team, we wanted to go broader. We looked at the Johns Hopkins Cancer Center, which is where we started our recruitment efforts, but then wanted to go beyond that to the Johns Hopkins Clinical Research Network. And this is where we focused our part 1 and part 2 of our study, looking at how we recruited patients and clinicians. Here's a map that you can see of our Johns Hopkins Clinical Research Network. You can see Baltimore's towards the top. Just north of Baltimore is the Greater Baltimore Medical Center, GBMC, which is just north of Baltimore and Towson. As you move a little bit further, you have Anne Arundel Medical Center in Annapolis. And then as you go down the Mid-Atlantic seaboard and the 95 corridor, we have hospital representation both in Montgomery County, Maryland, D.C., and into Virginia. The idea was to try to incorporate a big academic medical center at Johns Hopkins in addition to community-based hospitals. This is where we recruited part 1 and part 2 of our study. And going beyond that, we wanted to go a little bit broader. So we knew we had a really unique perspective looking at medical centers, both at an academic setting and as well as the community setting, but wanted to sort of take it beyond the Baltimore regional area. So then our part 3 of our study looked at trying to look at a national sample. And with this, we used an internet-based survey approach. And this, again, is where our stakeholders were really instrumental in making sure we got information out to patient groups, professional groups, using their social media networks, et cetera, to really get this internet survey out, to get cast a wide net, to get a lot of respondents. So as you can see on the bottom is where we did our part 1 and part 2, and as we expanded to part 3 in our internet survey. Some of the key things that we took away from this was we felt like it was critical to employ stakeholders from the very beginning of the process, from study design all the way through implementation and dissemination. They were involved in every part of the way. We really felt like we didn't just want these stakeholders listed on an application, but we had them together. We brought them together periodically in person as well as on the phone. They helped us triage problems, helped with study design, as well as moving forward. We casted a wide net, so we had a very broad group of stakeholders that were diverse in education, gender, ethnicity, educational background, as well as experience, to making sure we had a wide representation. And we, as I mentioned, that helped us with study conduct and effective dissemination. And finally, if you want to hear more, read more about how we did this, we did publish these findings in the Journal of Community and Supportive Oncology about how we implemented our stakeholders along the process of this program. And with that, I will turn it back over to Claire to talk a little bit more in detail about our 3-part mixed method study.
There was a pointer up here, but I lost it. But I want to thank Alyssa for her cooperation and collaboration throughout this project. And now I wanted to share a bit about our methods and results. So as I mentioned, the first part of the study looked at current approaches for displaying data to find out what patients and clinicians found helpful and what they found confusing. And so we showed different examples of data display formats, some of which we've seen this morning. So this is bar charts of average changes at 9 months. These are bar charts of the proportion meeting responder definition. These are cumulative distribution functions that the FDA has suggested. And these are line graphs of scores over time. This particular version includes confidence limits. We also showed a version without the confidence limits, as well as a version normed to a general population average. And I'm not going to go into details on part 1 or 2, but just give you a taste. And what we found was very wide variation in the accuracy of interpretation, not just among patients, but also among clinicians. And for questionnaires where higher scores were better for function and worse for symptoms, people got confused. They did have suggestions for us, which we tried to follow, but at the end of the day, both patients and clinicians preferred the line graphs of scores over time, with the clinicians valuing additional statistical details such as p-values and confidence limits, whereas patients not only did not want that information, but found it detrimental to their understanding. So because of this, we actually broke out how we looked at the presentation of research study findings so that we had one stream of research focused on how do you present this information to patients and like educational materials or decision aids, and a separate stream focused on how do you present the data to clinicians, such as in journal publications. And again, we also focused on individual level data, but that is not the focus here. If you want to find out more about part 1, we summarized our results in this publication. In part 2, we used what we thought was a very innovative approach of partnering with clinicians and patient stakeholders to develop the improved presentation formats. And so we used an iterative approach that I wanted to walk through with you. What we did is we took the results from part 1 and our research team met and said, okay, these are the things that emerged from the qualitative interviews that we need to try and improve on as we refine these data display formats. And then we had formed work groups based on volunteers from our part 1 interview participants who said, yes, I'm willing to work with the research team on their project. And so we met with this patient and clinician stakeholder group and said, these are the issues that emerged from part 1. These are the things we're considering doing about it. What would you recommend to us? Based on the feedback from the work group, we narrowed down some data display formats, and we tested those in additional individual interviews. And then we took the results from those individual interviews to our stakeholder advisory board. And we went through this process separately for each of our 3 applications, for individual patient data, for presenting research results to patients, and to presenting research results to clinicians. So based on the findings from part 1, we had several key questions that we needed to address. Both patients and clinicians endorsed line graphs for displaying the data, but we decided that the data display format does not drive the analytic strategy. The analytic strategy drives the data display format, so we wanted to address both how to show average scores over time, as well as the proportion meeting a responder definition. And then we wanted to figure out how we could deal with the issue of directionality to make it clear whether higher scores were better or worse. how to deal with scaling, normed versus non-normed, and for clinicians, how to identify statistical significance and clinical importance. So the results of part 2 were the formats that were tested in part 3, and for patients, we tested 3 different proportion formats: pie charts, bar charts, and icon arrays. Now, it's notable that we tested pie charts. They were not included in part 1, but they were recommended to us. Previous data in other contexts do not support using pie charts, but we said we should go ahead and test it, and we did. So I'll share those results with you in a bit. We also looked at 3 different approaches for showing line graphs of mean scores over time. This is an example of the more line graphs. This is where higher scores represent more of what's being measured. I found the pointer. So here, higher scores are better for physical and emotional functioning, but lower scores are better for fatigue and pain. This is an example of the better line graphs. We did not change the scoring of the instrument, but we flipped the axis so that 0 was on top, and this way lines trending up were always better. And then this is an example of normed line graphs where everything was centered on the average for US adults. To highlight some of the features that are consistent across all of these displays, we provided as clear separation as we could between the function domains and the symptom domains, so if they were scored in different directions, that would help people interpret the data. We colored the lines and the labels. We used clear wording on the x-axis. Patients did not understand what randomized meant. We provided headers that specified how to interpret what a line going up means. And we included descriptive labels on the y-axis, both to help understand what the score means, but also implicitly tells you about directionality. For clinicians, we tested very similar formats, except for we did not do pie charts because no one could imagine seeing a lot of pie charts in journals. And everything was done in black and white because still a lot of things are printed out in black and white. So these are the exact same pie charts, but the other thing we did for clinicians is add in p-values. I would note that all the data that is on these figures that I'm showing, the data is the same, only the formats are changing. So these are our bar charts of the proportion meeting or responder definition. And then for line graphs, we also did the more format, the better format, and the normed format. These are exactly the same, just in black and white. But we added 3 additional variations on the lines. Some variations just showed completely plain lines. Others added an asterisk for clinical importance with a legend that explained what that meant. And then others added confidence limits on top of that. So if you want to learn more about how we worked with stakeholders to develop these presentation formats, those results were published in Supportive Care in Cancer. So finally, I'm going to talk about the results from our Part 3 study. As Alyssa mentioned, we did both an internet survey and supplemented that with one-on-one interviews with patients and clinicians from the Johns Hopkins Clinical Research Network. For the internet survey, it was self-reported cancer patients or survivors, self-reported cancer clinicians, or self-reported pro-researchers who did not have to focus on cancer. But our one-on-one interviews purposefully sampled based on education, cancer type, clinical site, and clinician specialty, and we did that also in parts 1 and 2. So we had about 2,200 respondents overall, and they were randomized to one of 30 versions of the internet survey, and I'll go through what those versions were. For the data presented to patients, we collected data from patients, clinician, and pro-researcher respondents, but for the data presentation to clinicians, we only randomized clinicians and researchers to that stream. I'm going to go over the survey design in more detail, but the main point I want to make is that in testing the different formats, we kept the accuracy questions the same and the data in the formats the same, so only the way the data was displayed differed. So we asked questions of interpretation accuracy, we asked questions of clarity to rate the clarity, and we also asked them to select which format they thought would be most useful. For the one-on-one interviews, they basically completed the internet survey, but they thought aloud as they did so. Our analysis was descriptive summaries of the accuracy questions and clarity ratings. We used chi-square Fisher's exact testing for the most useful format. We used multivariable GE logistic regression to further explore interpretation accuracy and clarity. And we did qualitative analysis, not just of the one-on-one interviews, but the very extensive open-ended comments we got from the online survey. So first I'm going to show you about how to present the results to patients. Our survey here included 629 cancer patients or survivors, mean age 58, predominantly female and white, with 23% who had not graduated from college. We had 139 clinicians, mean age 44, mean years in practice 16, and 249 pro-researchers, mean age 45, with 46% with more than 10 years experience. For our one-on-one interviews, it was just 10 patients and 5 clinicians, but it was well distributed by our purpose of sampling. So we had 6 different versions of the survey to look at data display for patients, and the variation across the surveys was the order of presentation. So pies, bars, and icons were each shown first, second, or third in one of the surveys, with line graphs either seen after the proportions or before the proportions, but each respondent only saw one version of the line graphs because we thought it would totally confuse them if we started mixing around the line graphs. And this is just an example of the kind of interpretation questions we asked. Things like, at 9 months, on which treatment did more patients improve with regard to doing physical activity? Again, the questions asked were the same based on the order of the format seen, so that we could isolate any differences, not to differences in data or to differences in the accuracy questions, but solely on differences in the way the data were displayed. The answer choices were treatment X, treatment Y, or treatments are about the same. For line graphs, we asked similar questions, such as at 12 months, on which treatments are patients better able to do physical activities. For proportions across patients, clinicians, and researchers, the bar chart seemed to perform less well, and our multivariable analyses, this emerged more clearly. So both the pies and the icons were more accurately interpreted than bars. For the clarity, you see a very clear and consistent stepped rating, with pie charts being rated most clear, followed by bar charts and icon arrays. And again, this emerges in the multivariable models where pies are considered preferable to icons and preferable to bars. In terms of selected quotes, some people said, pie charts are easy. Some people are against pie charts, and one of my favorite quotes is, a pie chart is appropriate at a baker's convention only. Bar charts, some people like this side-by-side comparison, but others thought it was more challenging to interpret the data that way. And for the icon arrays, people like the personalization of the data, but they were considered to be very busy. Icon arrays are generally used in the risk literature where it's very small number of colored figures. And pie charts were also the winner in terms of being rated as most useful, with patients, clinicians, and researchers all putting it on top. It was statistically significant for all but the researchers. In terms of line graphs, you don't see a super clear rating in the descriptive analysis, but what emerges in the multivariate analysis is that the line graphs where higher scores were always better, were more accurately interpreted than either the normed or the more versions. More performed better than normed. And the clarity ratings tended to favor better line graphs only when compared to more for somewhat clear. So the clarity ratings weren't super different. In terms of the selected quotes, people like seeing the scores over time, but they get confused with the directionality changes. If you show them a more version, they say sometimes lines going up is better, sometimes it's worse, that's confusing. If you show them a flipped axis, they say, I don't understand why 0 is at the top of the y-axis. And then for norm data, patients can get confused about where these data come from. So in summary, our pie charts came out as most accurately interpreted, most likely to be rated clear, and rated best for proportions. And the line graphs with higher indicating better outcomes were more accurately interpreted and more likely to be rated clear than the more line graphs. These findings are in press for the line graphs and under review for the proportions. Finally, I just wanted to share our results related to presenting data to clinicians. For this, our final sample was 233 clinicians and 248 pro researchers, supplemented by 10 one-on-one interviews with clinicians. For this one, we had 18 different versions of the questionnaire because we had the 3 different variations on the line graph. So everyone only saw one kind of line graph, better, more, or normed, but we varied the order in which they saw confidence limits, clinical significance, and plain versions. And then we also showed the pies before bars and half the versions, and bars before pies and the other half of the versions. So that's how we ended up with 18 versions. So if you look at the accuracy of interpretation, it looks pretty pitiful, with very few clinicians and researchers getting both questions correct. And I just want to explain that finding. So one of the questions was, which treatment did patients improve more related to doing physical activities? So if you look here, more improved on treatment Y, but the p-value is not statistically significant. So we considered the correct answer to be about the same. But because many people picked treatment Y, we reanalyzed the data to look at what proportion got the absolutely wrong answer. So they put treatment X if the answer should have been treatment Y. So these results should be a little more reassuring. And there was actually no difference between bar charts and pie charts for getting the answer correct. However, pie charts were less likely to be interpreted incorrectly. So pie charts performed better there. And then for the clarity, there were really no differences, and that is shown in the multivariable models. In terms of selected quotes, some people like pies again, but others felt uncomfortable with the idea of pies. And then for bars, they found that bars were more easier to read or that it took them longer to compare. And I misspoke earlier. I said we didn't use pie charts for researchers and clinicians. I meant to say icon arrays were not used for clinicians and researchers. And then in terms of most useful, we did not find statistically significant differences, although bar charts were a trend among researchers. When you look at the line graphs and the multivariable models, and when you look at the proportion getting the answer incorrect, normed versions were inferior, and those are shown in the multivariable results. So normed were more likely to be incorrect compared to better and compared to more. The differences were less distinct for getting the answer correct. And in terms of the clinical significance, we added questions like, for which domains are average scores clinically significantly different between treatments at 6 months? So the answers are pain and fatigue. And across the different versions of the survey, certainly pain and fatigue were answered more commonly than physical than emotional, but it's not that they were universally identified as being clinically important, even with the asterisk. And then when we show the confidence limits, we asked questions like, for fatigue, at which time points are average scores statistically significantly different between treatments? And again, the highest ratings were for the ones where there was clear separation between the confidence limits, but even when there was very clear overlap in the confidence limits, some were selecting them as being statistically significant. So this is just a caution in terms of how reliably these data are being interpreted. In terms of clarity, we again find that the normed are inferior, with both the more and better versions rated as being more clear. And then selected quotes are the more confusing because the directionality changes, but the better is confusing because if you think a line going up at fatigue would be more fatigue, not better fatigue, although if they figured out that we had flipped that axis, then they thought it was clear. For the normed, it was harder to see the magnitude of the difference. Some clinicians and researchers like the simplicity of just the asterisk for clinical significance. Others appreciated the addition of the confidence limits. So when we asked them to select their favorite line format, clinicians and researchers picked some version with confidence limits or clinical significance. So to summarize, both clinicians and researchers are unlikely to pick the incorrect treatment, but they were more likely to be incorrect with bar charts. There were no differences in clarity, and researchers tended toward picking bar charts. For the line graphs, the normed versions come out inferior, but the inclusion of clinical importance or statistical significance is appreciated. And all of this is in much more detail in this publication. So finally, to conclude on our next steps and returning to our theme of stakeholder engagement, at the end of our project, our stakeholder advisory board said that the evidence we had generated is sufficient to inform recommendations for data display, but did not define those recommendations on their own. And so they recommended that we bring together a broader group of stakeholders to develop stakeholder-driven evidence-based standards. We were pleased to get additional funding from PCORI to conduct a Delphi process, taking the results from our study and from the few other studies that had looked at this question, and those results are currently under review. So with that, I want to acknowledge our team, especially our patient co-investigator, Alyssa, and our team of stakeholder advisors, and Michael Brundage, the co-principal investigator. Thank you very much.
Great. So thank you, Dr. Snyder and Ms. Bantug. So we are now, it's about 10 o'clock. We're about 10 minutes ahead of schedule, and we're up for a break?
Yeah, for a break, but I just want to remind anybody who wants to speak that is not already on a list to sign up out back, because we'll pick up that list after the break. So if you want to speak, make sure that you are signed in and you sign the disclosure agreement.
So we're giving everyone 15 minutes, so please be back in the room at 10:15. Could people please start returning to their seats? We're about to restart.
If everyone could take their seats, we're about to get started. Dr. Bosch, you can be making your way to the podium.
Great. So thank you. As everyone's getting back to your seats, we're restarting. And our next speaker is Ethan Bosch, a professor of health policy and management and the director of the Cancer Outcomes Research Program at UNC Chapel Hill.
Thanks very much. Nice to be here, and thank you to CMS for the invitation to speak to you today. I'm a medical oncologist and a professor of medicine at the University of North Carolina. I conduct clinical trials, I see patients, and my research group has done work around patient-reported outcomes for many years, and I'll describe some of the work by us and others as pertains to the questions posed to the panel today. I'm going to try to be practical towards the specific questions that the panel will be addressing per my charge from CMS. So I'll begin with some general comments and some evidence around the collection of patient-reported outcomes data in oncology clinical research in general, and then I'll turn very specifically to the tools that CMS selected for evaluation today. These are my disclosures. I conduct research largely funded by the Patient-Centered Outcomes Research and the National Cancer Institute. I have received funding for the development and testing of patient-reported outcome tools. So I'm an oncologist, and when I sit with a patient and we make a shared decision about treatment, one of the very first questions that they ask, in fact, one of the first questions that we both ask, is how will the patient feel with the product? How did patients like them previously deal with the treatment? How did they feel with the treatment? And without this information, we have an impaired ability to make informed decisions. People like to know what to expect. Right? If somebody's going to go through a medical procedure or medical treatment, it would be nice to know how it's going to make them feel and make them function. And without this information, I would argue that we have an incomplete understanding of a product's characteristics and a limited understanding of the longitudinal patient experience. It's missing. Now, some have argued, well, we collect this kind of information in clinical research. Clinicians really understand the patient's experience. This is often documented either in symptom forms or in toxicity assessment. And this graphic shows some data from my group from a number of years ago, where we did a very simple tracking of about 1,000 patients enrolled in clinical trials who were self-reporting their own symptoms, and simultaneously their clinicians were systematically reporting on those patients' symptoms. And you can see the cumulative incidence of the patient-reported symptoms in orange, the cumulative incidence of the clinician-reported symptoms in blue, showing that I and my colleagues, many of us in this room, substantially underestimate the symptom burden that our patients are experiencing by about half. Now, when thinking about adverse events, and Paul Klutz from the FDA spoke about one of the key domains of patient-reported outcome data collection, which is around symptomatic adverse events, this information is currently collected from clinicians, right? In oncology trials, we complete information using the CTCAE, the common terminology criteria for adverse events. This information is not typically collected from patients. And, unfortunately, when it comes to symptomatic adverse events, this information, it turns out, is not reliable. As shown in this study that was led by Thomas Atkinson at Memorial Sloan Kettering Cancer Center, in which a really simple experiment was done. Patients who were receiving treatment on trials were coming in to receive their therapy, and they were seen independently by two different clinicians. one generally in the office for a toxicity check and one in the infusion suite. This was generally within about 10 minutes of each other. There were no treatments in between. Both were blinded to each other and completed CTCAE symptoms. And you can see down the middle of this graphic for a number of very common symptomatic adverse events reported with the CTCAE. We see the interclass correlation coefficients. For clinical trial grade data, these numbers should be in the 0.8, 0.9, somewhere in their range. And you can see that these numbers are substantially lower, showing that if I and my colleagues see the same patient on a clinical trial on the same day at the same time, that we often disagree with each other. This really raises questions about the reliability of clinician-reported symptomatic adverse event information. We as clinicians are creating a lot of noise, and this is because it is extremely difficult for one person to understand another person's experience with symptoms. And I would say that I myself as an oncologist I and my patients have been a part of many of these studies, and I really do know better than any of my colleagues. This is probably just dependent on the psychodynamics of interactions and the logistics of clinic visits. Now, why is this important? Well, here I show not a CART therapy, but this is a table from Taxotere, a drug that I commonly use in my practice. And this is taken directly from the FDA label. This is the adverse reaction table from the TAX 327 trial, one of the registration trials for Taxotere. And we see that more than half of the adverse reactions are symptoms, right? Highly subjective phenomena like nausea and taste disturbance and dyspnea, fatigue, and myalgia. But currently all of this information is reported by clinicians, and unfortunately we have to really question the precision and reliability of this information. We can do better, as has been pointed out in a couple of the prior presentations. So what about the applicability of patient-reported outcomes to CAR T therapies? There are several domains of potential interest that align exactly with those domains that the FDA previously presented to you as being of high interest to them in the evaluation of oncology drug products. Number one, symptomatic adverse events. We can understand the short-term toxicity profile of these products. We can look at the longer term, right, the late effects of these therapies. Yes, it's wonderful that people are being cured who did not have such a hope previously, but how do they feel? How are they doing? What can they expect? And in order to manage people's late toxicities, we need to know what their late toxicities are, and if we don't collect that information, we won't know. What about earlier changing symptoms that might flag an impending untoward event, right, like CRS? There might be warning signs that come best from the patients if we're monitoring them. Second, physical functioning. If my patient is in bed all day, I'd like to know about that. And I think that future patients would like to know if prior patients had that experience. And finally, change in disease-related symptoms, which Dr. Klutz already discussed in detail. Now, CMS identified a host of tools that they have asked the panel to score in various domains today. I won't comment on the quality of your grading questionnaire today. Maybe you can extract from the presentations about the psychometric properties of your own tool that you'll be using. I'm going to describe each of these tools briefly. Catherine already did this nicely. I'm going to expand on that a little bit. And I want to note that the information I'll be providing was extracted through a structured review of the scientific literature and of clinicaltrials.gov data by Dr. Thomas Atkinson, who's here today. He has more hair than in the picture here, but he is more qualified than I am. I would say he is a psychometrician. He has been involved in the development and evaluation of patient-reported outcomes tools. I am but a humble oncologist conveying the message today. So these are the tools. Catherine already went over these, so I won't belabor them, but I'm going to go through each of them in a little bit of detail now. And I would note that according to clinicaltrials.gov, there are 11 trials that have included patient-reported outcomes for CAR T. This does not necessarily include registries or post-marketing evaluations that might not necessarily report to clinicaltrials.gov. But of the 11, 2 use the Puros CTCAE, 9 use the EORTC QC30, and 2 use PROMISE. Again, this is from clinicaltrials.gov, and that's the limitation of our evaluation. If somebody didn't post their trial, we wouldn't have seen it. Hopefully everybody did. So in addressing question number 1, which just to remind everybody here, question 1 posed to the panel is how confident are you that each of the following PRO assessments are valid and generalizable to the Medicare population, and panelists are asked to assign a score of 1 to 5 for their level of confidence. We looked at 2 different elements of each of these tools. So you look, within the questionnaires, right, when we look at a PRO question, we try to tease apart the meaningfulness, right? One of the domains of interest is, is it valid? And the other, is it generalizable? So we tease this apart. So for part 1, valid, we looked at what are called the measurement properties. These are really common characteristics of measurement tools that help us to understand if it's a good tool, if it's meaningful, if it's reliable. So we looked at first what's called content validity. This is whether patients were involved in the development of the tool to understand if the terminology in the questions is widely understood by patients, and if that terminology actually maps to the concepts that you're trying to evaluate. If it's a pain questionnaire, are you actually measuring pain? Or are you measuring, fatigue and, other stuff? Number 2, reliability, right? This is test retest. If you ask the same person the same question over and over again, will they give you the same answer because the responses and the questions are really clear to them, or are they all over the map because the question isn't well structured and it's confusing, right? If you ask me, one day if my pain is intolerable and another day if my pain is excruciating, that's not a good question. I might not, I might feel both. The third is what's called construct validity. This is whether the question if it really reflects the underlying thing that you're trying to measure. So if you're asking about sensory peripheral neuropathy, are you really measuring sensory peripheral neuropathies? This is generally done by looking at the correlations or the associations of the responses in those questions to underlying anchors. So, for example, if you're looking at peripheral neuropathy, you would expect to see different scores in people who are on taxanes or platinums or other products that might be expected to track with neuropathy. And then finally, clinical responsiveness. This is really change over time, right? Do scores change over time as expected? So that's the valid part. Then for generalizable, we looked at whether the tool has been used in CAR T. As I already explained, they're new, it's a new product, so there's not that much accumulated experience. Although there are 11 trials, it's not bad. But we looked also at the use of these tools in the 65 and older population, just to look at general pertinence and prior use of the tool in the Medicare population. Now, question 2 is a little bit more nuanced, I would say, and I want to just take a moment on this before I launch into each tool. To remind everybody, question 2 asks, considering all PRO assessments in question 1 with greater than or equal to a score of 2.5, please vote whether or not those PRO assessments combined have available supporting evidence on each of the following desired characteristics. And there are 8 of them. So I'm just going to very quickly explain my interpretation. My interpretation may be different from other people's interpretation, but this is how we thought of this. A, the breadth of the measures in emotional, social, and physical well-being. We looked at whether the PRO tool includes those specific quality of life domains of emotional, social, and physical well-being within the assessment of the tool. That's a little more straightforward. B, quick throughput to apply to clinical studies. We thought, does this mean you can kind of get it up and going, pretty quickly for a trial? C, is it transferable to community practice settings? So we just simply looked, has it been tested and used in community settings and trials? D, the measures are not sensitive to differences in age. So we looked at whether there's evidence that age alone does not sway the scores, right? So if you have people of differing ages and you put age into your model, it doesn't mess with your results, your findings. E, the same question, but for line of therapy. And so similarly, we look to see if line of therapy sways scores. F, the measures are not sensitive to comorbidities. This is more challenging because you can look at whether comorbidities themselves impact scores, right, the way that we do, say, case mix adjustment for quality assessment in clinical practice. But, this could be a problem if the comorbidity has symptoms, right? If you have a patient with severe rheumatoid arthritis, they might have pain from their rheumatoid arthritis, and they might be reporting on that pain. So if you have a question that is agnostic to the etiology of the pain, you might pick that up. So that's a little bit more challenging and nuanced, and I'll address that a little bit as I go. G, the measures are generalizable to study of combinations of therapies. We simply looked, has the tool been used with combination therapies and comparing combinations versus single agent. And then finally, used a net benefit analysis based on symptom burden and well-being. I have to be honest, I found I wasn't sure exactly how to interpret this. The way that we used it for our analysis, we looked to see if the tool involves some sort of global metric for the overall impact on the patient of the patient-reported outcomes. I think there's another way you could interpret this, which would be, has the tool been used in net benefit analysis of the value of a treatment? And if that's the case, almost all of the tools would be a yes. That's not how we interpreted it. Okay, so I'm going to get right into it. So the Puros CTCAE, the patient version of the CTCAE, as a disclaimer, when I was faculty at Memorial Sloan Kettering Cancer Center, my group worked under contracts to the National Cancer Institute to assist in the development of this tool. We do not currently derive any funding for this. This tool is the intellectual property of the NCI. So I may have intellectual interest in this tool, but no financial interest. Again, as Paul Klutz mentioned in his FDA presentation, this is what we call a library, a PRO library. It's a bunch of individual items. You can pick and choose from the library. If you want to measure fatigue, you choose that item. If you want to choose sleep disturbance, you choose that item. It was developed for the explicit purpose of patient adverse event reporting, really symptomatic adverse events. It only includes symptoms, not other kinds of AEs. You wouldn't ask a patient about retinal detachment, for example. There are 78 distinctive adverse events included. It is mapped directly to existing standardized lexicons for adverse event reporting, specifically CTCAE and MEDRA, which is commonly used in non-oncology trials. This is free for use, no license is required. There is an adult version in use and a pediatric version that's close to done. So these are the questions that I alluded to earlier, looking towards your question one, areas of valid and generalizable. If you look at the measurement properties for whether we think it's valid, the tool does well across all of these categories: content validity, reliability, construct validity, and clinical responsiveness. It's in use in 2 CAR-T trials, and it's been used in numerous trials in the Medicare 65 and older population. In looking at question 2, for your specific questions, for the breadth of measures in emotional, social, and physical well-being, this is really non-applicable for this tool. This is an adverse event tool. It's not looking at quality of life per se in terms of social or emotional or physical well-being. I mean, it alludes to that, right? Adverse events can impact these things, but it's not directly measuring them, so that's not applicable. It's ready to go. You can drop it into a clinical trial tomorrow, so there's quick throughput. It's transferable to the community setting. It's been tested extensively in that setting. The measures are not sensitive to differences in age or line of therapy. Comorbidities don't impact the scores, but again, if you have a patient who has a lot of symptoms or side effects from their arthritis drug, that could be picked up. It's generalizable to combinations. It does not have a measurement of global net benefit. The tool can be used to evaluate net benefit, if that's your interpretation, but there's no overall general assessed global measurement of net benefit in the tool. The Medality, the MD Anderson Symptom Inventory, is a very well-established tool. It's been around for a long time. It has 19 items, 13 specific symptoms, 6 questions about how those symptoms interfere with functioning. This is a symptom questionnaire, not a quality of life questionnaire. It is widely used in clinical trials. It also performs very well in all of these question 1 areas around it being valid and generalizable. It hasn't been used in CAR T, but it's been used in many trials in the 65 and older population. It also does very well on the question 2 items. It does allude to emotional, social, and physical well-being in that it looks at the impact of symptoms on these areas. It does very well in all of the other categories, quick throughput, community settings. It's not sensitive to differences in age, therapy, or comorbidities with the same caveat I've mentioned earlier. It has been used in many studies with combinations. And again, net benefit, it does have a question asking about overall impact of symptoms on well-being. So again, depending on your interpretation of this, I would say probably it's a yes there. The EORTC QLQC30, also a very, very well-established, well-traveled tool. It has 30 items, 5 for physical functioning, 14 symptoms, and multi-item scales for cognitive, emotional, physical, role, and social. So it has it all, right? It's got the physical functioning, it's got the symptoms, it's got the quality of life domains. It's not designed for adverse event reporting, however, so that's not a purpose of it, but for efficacy or effectiveness, this is a well-traveled tool. It also does extremely well across all of these valid and generalizable categories, although the content validity wasn't initially tested because the tool was developed before content validity was a prominent expectation in tool development. This was done subsequently. It performs extremely well in your question 2 items, really across all the categories. I won't belabor these because you have my slides, except to highlight H again, the net benefit. It does ask about overall quality of life. It does have sort of these overall health status kinds of questions. So by the criteria that Dr. Atkinson and I applied, I would say it probably is a yes there. The University of Washington Quality of Life tool is not a well-known tool. This was included in CMS's packet, and I was asked to comment on it, and we did do all the searches on it. It has 6 items for physical functioning, 6 for psycho-emotional function. It doesn't really do as well in question 1. Content validity was not established. Reliability, not in English, only in Spanish and Chinese. It has had construct validity and responsiveness assessed. It's really been used in a very limited number of trials, both in the under and over 65 population. It has not been used in CAR T. And again, it really doesn't perform so well in question 2. Probably can be used quickly in clinical trials. It just hasn't been used in that many clinical trials. It's unclear whether age or line of therapy or comorbidities impact the scores. PROMIS, the Patient-Reported Outcomes Measurement Information System, is a brief, precise, fixed, and or tailored tool. It was developed with NIH funding. This is also publicly available. It includes physical, mental, and social well-being, as well as pain, fatigue, and sleep. This tool was meticulously developed. It offers short forms. It offers this sort of computerized adaptive testing approach, kind of like, if your kids took the SAT, where, depending on how you answer one question, there's a subsequent question to get a more precise estimate of what your actual score is. But they're also single items, so it's really flexible. There are adult and pediatric versions. It does extremely well in all of your question 1 categories. It's being used in 2 CAR T trials currently. It's been used in many studies in the 65 and older population. As you can see above, its measurement properties really have been pristinely tested. It also does extremely well in your question 2 items, really across the board. Again, I raised that question about H, the net benefit. Again, it does have overall quality of life items in it, so I guess, I would probably say yes, depending on how you interpret that. The real limitation here is that there are only a small number of domains that you can measure with PROMIS, and so if you want, a wider number of things to be measured in the trial, you're going to need PROMIS plus something else. But for what it measures, it really is excellent, in my opinion. The ESRA I was asked to comment on as well. This really is not well known. As alluded to in Catherine's presentation, this is really not a well-known tool. This is not a PRO measure. It's an electronic questionnaire system. So it's not really a PRO. It happens to include 3 PRO measures in it. the QLQC30, which you've heard about, the PHQ-9, which we haven't talked about, which is actually an excellent measure of psychosocial distress, anxiety, depression, which is commonly used to assess depression, and the symptom distress scale, which is really kind of a lesser used symptom scale. It's not really been well tested. It's been used in very few trials. And because it's been used so seldom, because it's not a PRO instrument, I didn't even go into evaluating question 1 and 2. It wouldn't do well because it just hasn't been tested in that way. To me, it's like non-applicable to these questions. The FLIC, this is a PRO tool, but also really not well known. It's an old measure. It has 22 items, looks at physical, emotional, social function, well-being, pain, and nausea. We could only actually find one cancer trial using this tool, so really not well traveled in the oncology space. And so again, we really didn't go through the 1A, the questions for 1 and B for this because there's just no data to evaluate. It really wouldn't perform well, again, in our opinion. This graphic, unfortunately, didn't come over well when conveyed to CMS. It may have come over better in the slides that were printed, or maybe it was censored. But the double question marks from me were smiley faces, and the other ones were sad faces, but maybe CMS felt I should be a little milder. But in our opinion, the ones with these double question marks are tools that are well established, well tested, perform well. And if I were designing a trial, with the caveats that Paul mentioned in his FDA presentation, we'd want to make sure that the tools are appropriate to the domains of interest. These are tools that I would be comfortable considering. The frowny face is not so much. All right, so just in the last 4.5 minutes before I finish up, there were some additional questions to the panel. Are there other PRO assessments to consider? I would say yes. There's one in particular that I'd like to highlight, and that's called the FACT GP5. This is a single item that asks people whether they are bothered by the side effects of their treatment. This is a global assessment of side effect burden. This is a very helpful companion to the Pro-CTCAE, right? Just to remind you, the Pro-CTCAE is the tool where patients answer individual items about their individual symptom side effects, right? Do you have sleep disturbance? Do you have taste disturbance? Do you have myalgias? This is a global to go along with it. This is a 5-point response scale. It's well developed. There's broad interest in using this. It's been alluded to in numerous past FDA and EMA presentations. Are there additional desired characteristics besides those in question 2? Yes, I think so. First, the general, what we call measurement properties. All these things that Dr. Atkinson and I actually commented on in our responses to you. Content validity, construct validity, reliability, sensitivity or responsiveness. These are really key measurement properties of an assessment tool and really both need to have been tested and demonstrated to perform well for a good tool. Prior testing in populations with cancer, the availability of language translations, this is essential, not just in the US, but particularly ex-US for international trials. And then, I'd say really importantly, does this include items that are salient to the CAR-T population? There really needs to be evaluation in this population, probably qualitative with interviews, asking patients about what's going on with them very broadly so that we can understand what are the outcomes that are salient to this population so we can then say, is this the right PRO instrument to use? And this is really on the sponsors, right? Sponsors spend a lot of money developing their measurement tools, conducting these trials. This is an essential part of understanding the patient experience. The sponsors should be going out to patients in their trials, asking what they're experiencing, so they can substantiate the PRO metrics that are being used in their trials, and particularly in their registries. I think in the real world, not just in the registration trials, this information needs to be collected. All right. In conclusion, patient-reported outcomes provide valuable information about the patient experience and about the characteristics of products that cannot be well captured in any other way. There are well-developed, available patient-reported outcome tools that can be used readily in CAR T trials. They could be used tomorrow. Yes, we can do more work to cone it down, to get more specific, to figure out what exactly would be best to measure, but these tools are shelf-ready in many cases, but we should do further work to really cone down and understand what are the outcomes of interest. Assessment of physical function, symptomatic adverse events, and disease-related symptoms should be considered in any given trial in oncology, including in this population. Thank you very much.
Great. Thank you, Dr. Bosch, right on time, and to Dr. Atkinson for his work to support the presentation. So now we are turning from our to the scheduled public comments portion of our meeting. Each speaker will be given 6 minutes to speak, and we have 6 speakers because one was unable to attend. And we are, as each speaker comes to the podium, I ask that the next speaker comes and joins at the chair to keep us moving efficiently. And just as a reminder to introduce yourselves and to disclose conflicts of interest. And our first speaker is Dr. Catherine Flynn.
Hi. So just a note that we submitted slides before we knew how long we would have to talk, so I will be skipping over some slides, but they are all available, of course, online. So yes, so I'm Catherine Flynn. I'm an associate professor of medicine at the Medical College of Wisconsin, and I am also, as of November last year, now senior scientific director for patient-reported outcomes at the Center for International Blood and Marrow Transplant Research, the CIBMTR. So I'm here representing the CIBMTR. CIBMTR paid for my travel to attend the meeting. I don't have any personal financial disclosures related to CAR T, but CIBMTR as an organization receives federal funding from NIH, HRSA, and the Navy, and as you heard earlier today, has a cell therapy registry contract with Kite. So CIBMTR, for those of you who aren't aware, collects and maintains clinical outcomes data on all allogeneic transplants as required by US law. Centers also voluntarily submit data on auto transplants, and worldwide centers additionally submit data voluntarily. So related to blood and marrow transplant research, the registry has information on nearly 500,000, 475,000 patients are included in the database. And we are now in the process of implementing an e-PRO system that will be available for use by the registry and the affiliated trials network, the BMT-CTN. So I'm going to skip this one, if I can. No. There we go. So we looked last year at the BMT-CTN studies that have collected PROs. And of 18 trials performed since 2004, half of those had included as a primary or secondary outcome a patient-reported outcome measure. Many different measures have been used in these studies, most commonly the SF36 and FACT-BMT. But we were looking to make some recommendations going forward and thinking about the implementation of this ePRO system, what to recommend. And so I'm having trouble with this. Okay, I have to press it really hard, I guess. Okay. So we had a couple of recommendations. First, to use the same core measures in all research studies of HCT patients, use a system that's free and easy to access, try to ensure a low burden for the patient who's, of course, undergoing difficult treatment, using a single versatile measurement system for core concepts, supplemented with additional measures as necessary. And so thinking about the registry context, the core system that was recommended in this article by Brown and Shaw was PROMIS. I'm going to... Okay, even pressing really hard, I'm having some difficulty there. Okay, I don't know if it needs new batteries potentially, but...
Don't worry, you can have another minute. So
okay,
don't
great.
Start
all right, thank you. So we've already heard about PROMIS. I'm going to not go into detail there, but it met those recommendations that we were hoping for. Okay, so just to reiterate a point just made in the last talk, really the most appropriate PROs to collect in cell therapy are unknown, so there really is some foundational qualitative work that needs to be done. We can probably make some good guesses about some of the domains that will be that'll need to be measured, but to get into more specifics, there does need to be some additional work done, I think. However, once relevant constructs are identified, there are absolutely multiple available high-quality measures that can be used and can choose the appropriate measures and time points at that time. Centers need a structure and process to systematically collect PROs, and so what I'm going to do with my remaining couple minutes here is just to describe the components of our CIBMTR ePro system. So as you can see here, the ePro system is the integration of electronic patient-reported outcome collection with our existing systems for collecting other information, the clinical information. So in the bottom right, we use Salesforce to track our studies, participants, time points, activities. The bottom left, that's our integrated data warehouse where the clinical outcomes data from multiple sources are stored for research retrieval. Top left, as I mentioned, we did identify promise measures as that core system, but certainly other measures can be added as necessary, and so certainly for some of the trials within the BMT-CTN, already we're adding items from the PRO-CTCAE for those specific studies. And then to the right, note that we're using Qualtrics as the patient interface for administering patient-reported outcomes, so a very flexible, user-friendly system for patients to complete those PROs. So this system was developed with funding from the Navy grant and our partner, the National Marrow Donor Program. And our pilot ePro study just started this summer. It's a 6-site pilot trial where we're examining quality of life using promise measures in patients that are part of the CMS MDS study. This is just cross-sectional to explore the feasibility of the use of our system, but certainly longitudinal studies will be feasible as well. There is just a note here, this is just a brief overview of kind of the study procedures, but to note that significant planning and effort is required to manage this central coordination of multi-site PRO data collection in terms of following patients at multiple sites and getting there, being able to contact them directly when previously through the registry they are only contacted by their local center. And so for the CIBMTR directly to contact them is new. And then the last thing I wanted to mention is related to this, we've recently organized a multidisciplinary working group of about 30 or so people with expertise in many different fields as part of a late effects task force. And again, this is in the context of BMT, but our goal is to develop a strategy for the collection of late effects in patients that are reported to the CIBMTR. So of course, it's a very heterogeneous population who's receiving transplants. And so focusing on which populations we should focus on to get kind of routine PRO collection, what domains we need to focus on, what measures to use, what time points. These are all questions that we're answering within the context of this task force. And we have a 9-month time frame. We started this summer and we're going to present recommendations at the Transplant and Cellular Therapy Conference, which is in February of 2019. That's it.
Great.
Thank you.
Thank you. Right on time. Our next speaker is Karen Chung, the Senior Director of Health Economics and Outcomes Research at Juno Therapeutic.
Good morning, everyone. Again, my name is Karen Chung, Senior Director of Health Economics and Outcomes Research at Juno Celgene. I've been involved with in patient-reported outcomes strategy, analysis, communication for over 15 years in the pharmaceutical industry, and I'm currently employed by Juno Celgene and do have stock options with them, as well as other companies. Celgene is developing investigational CAR T-cell products and which are not FDA approved, and any data we discuss today is subject to change. CAR T-cell agents are novel agents which fulfill an unmet need in patients who have not responded to frontline therapy, including Medicare patients. They have limited effective treatment options as well as limited survival. CAR T-cell therapies have been administered across sites of care and as novel therapies have long-term follow-up to continually assess efficacy as well as safety. And while AEs are specific to each CAR T-cell therapy, AEs are being increasingly identified very quickly and managed very efficiently. And while PRO measurement is important as it represents the patient voice, it is very complex from the clinical trial perspective and even more so from the clinical practice perspective. Celgene is developing 2 CAR-T therapies which have the potential to significantly transform patient outcomes. JCAR-17 is a CD19-directed CAR T-cell therapy for non-Hodgkin lymphoma. BB2121 is a B-cell maturation-directed CAR T-cell, which is currently in clinical trials for multiple myeloma. The other was for non-Hodgkin lymphoma. Each CAR T-cell therapy has a unique targeted patient population, safety profile, and manufacturing process. As the science of CAR-T is rapidly evolving, we urge CMS to provide flexibility to consistently ensure patient access across all these disease states. While we strongly support the incorporation of the patient voice into clinical trials, we firmly believe PROs should not be a condition of coverage due to the significant barriers in the clinical practice. Again, while we don't think PROs are appropriate for coverage, we did want to take a look at the questions that CMS had asked the panel to consider. And of the 7 instruments that were delineated, we feel that 4 of the 7 instruments could be appropriate for clinical trials involving the Medicare population. The first is the PRO-CTCAE, which Dr. Bosch has mentioned. It does cover a wide range of symptoms, and so for symptom assessment, it's a very useful tool. The Modality, or MD Anderson Symptom Inventory, covers a wide range of symptoms. The URTC QLQC30, which we've implemented in the JCAR-17 and BB2121 trials, is a comprehensive instrument that assesses symptoms, functioning, as well as health-related quality of life. The last instrument is PROMIS, which is basically an item bank, which also covers various symptoms as well as functioning. This next question is really considering all these instruments together. And together, we feel that they do have a breadth of measurement, specifically in emotional, physical, as well as social well-being. They can be applied and have been applied to clinical studies and can be used in the clinical practice setting as well. We felt that they were sensitive to differences in age, lines of therapy, as well as comorbidities, and felt that they were also generalizable and can be used in combination therapy trials. Pro-implementation, from end-to-end, pro-implementation in clinical trials involves significant resources in terms of both budget as well as headcount. We need to support instrument selection, licensing, site training, data collection, analysis, as well as interpretation. PRO assessment in clinical practice is typically even more challenging due to the lack of infrastructure. Institutional barriers could include the healthcare provider burden, the additional FTEs that are necessary to coordinate administration and data collection, and the lack of consensus on which is the most appropriate patient-reported outcome tool to use. And then there's the scoring, the expertise needed in scoring, analysis, as well as interpretation. Perhaps even more notably are the patient barriers. And so we're asking these Medicare patients who are typically very sick, third line and beyond, to respond to these questionnaires. They may have poor performance status, and they may also face technology barriers as we move to more electronic platforms to collect this data. So it's something that they might not have the experience to really manage through well. So while patient-reported outcomes are key measures in hematology oncology trials, including the CAR-T therapies, there are important considerations, which includes the wide range of tumor types and stages, also the broad areas of concepts. Are we interested in physical functioning, disease-related symptoms, adverse events, or health-related quality of life? Which do we focus on? And so due to the diverse nature and range of symptoms across and within tumor types, as well as the administrative burden, assessing patient-reported outcomes with validated instruments is complex. Celgene has incorporated relevant PRO assessments in CAR-T clinical trials to complement clinical efficacy and safety data, and we feel is very important. However, while we feel it's very important in the clinical trial setting, we don't feel they should be a condition of coverage.
Great, thank you very much.
Thank you.
Our next speaker is Dr. Surbi Sadana from the Mayo Clinic.
Good morning, and thank you for this opportunity. I'm a hematologist oncologist, and I'm not a PRO expert, but I'm leading 2 studies of PROs, including one of CAR-T, and I just want to speak to the panel of the challenges we have faced in trying to design and lead this study. So here are my disclosures, and ASBMT is paying for my travel to this meeting. This data has already been shown, so I will not beleaguer this data anymore. However, CAR-T cell therapy is a novel therapy which has shown exceeding promise in patients who did not have other treatment options before. It has unique side effects, and some of the side effects we are not even aware about in the long term. Various approaches to assessing PROs have already been discussed in detail, and so I want to focus on the approaches of assessing PROs in patients with CAR-T cell therapy. We have conducted several studies in the last couple of years in hematology which have used various methods of assessing PROs. So let's focus on the challenges of conducting this study, and this is from my personal experience in conducting this study. So what is an optimal outcome that we should use, and what instruments should we be using? 7 instruments are being asked. We're rating 7 instruments today. In my study, I'm using a completely different instrument because on my clinical judgment, I thought that was a better instrument, along with some of the instruments we are using today. So even though we have validated instruments, not everybody agrees that those instruments should be the same in different studies. Second, how do we account for missing data? A lot of patients who are undergoing CAR-T cell therapy will have side effects, get into the ICU, and these patients potentially will have significant missing data that we will miss, leading to bias. A lot of times, patients come to referral centers like Mayo Clinic for their treatment, and then they go back to their local doctor. So if we are going to use long-term data, we might miss these patients who are now gone from the referral center. And then the third thing, do we just collect this data or do we do something about it? As a doctor, it's challenging. You're asking patients to give your symptoms, and then you feel you're ethically obliged to do that. This also keeps patients engaged. However, there are problems with that. It requires a huge infrastructure. It also requires consensus to say, when are we going to intervene? For example, if you ask a patient for pain, do we intervene for a pain of 7 out of 10, 8 out of 10, or 9 out of 10? Is 7 different than 8? And similarly for other symptoms as well. That would also require a lot of resources that centers in the community will not have at present. The other thing that is challenging, we want to assess how is a patient's quality of life in respect to the side effects they experienced initially. And that's problematic because right now, all the different CAR-T trials are assessing toxicities differently. Grade 3 CRS in one trial is not the same as grade 3 CRS in another trial. The management of toxicities at my institution is very different from management of toxicities at another institution. So this is going to impact how we interpret this data and what this data means. And then, as many people have already alluded, CAR-T cell studies are currently being conducted in various hematologic and oncologic malignancies, and currently are approved for 2 diseases, ALL, as well as non-Hodgkin lymphoma. We expect that soon they'll be approved for other diseases like multiple myeloma. And the short-term toxicity has really varied across different trials based on what construct and what disease. For example, a lot more CRS was seen in non-Hodgkin's lymphoma than is being seen in multiple myeloma. So how can we put all of these patients together with different diseases which have different symptoms, different constructs, and say we're going to measure all of these the same? And then what is our benchmark? As has been shown before, these patients with non-Hodgkin's lymphoma previously did not have many treatment options. Their median survival was 6 months, and now it's not been reached. So how do we decide what's reasonable quality of life or what's reasonable physical function in these patients? How do we compare them to historical controls, or even how do we compare them to their baseline? What's reasonable? So I think there's a lot of room for study at this point. We are conducting pilot studies at my institution and several other institutions to address what's the feasibility, where is the missing data, how can we do this better, and do we need specific measures specific to CAR T-cell therapy? And then in the context of a working group, we need to come up with a consensus before we design a larger scale study. I think at present we need at least 12 months to come up with consensus based on prelim data from our studies and the studies being done at other institutions. Thank you.
Thank you, Dr. Sadana. Our next speaker is Dr. Corey Abakoff, the Medical Director of CAR-T at Novartis.
Thank you very much for allowing me to speak today. I'm Corey Abakoff. I'm a medical director for the CAR-T program at Novartis Pharmaceutical Institution. My expertise is in pediatric stem cell transplant as well as adult and pediatric apheresis. I am a paid employee of Novartis. Kymriah, the Novartis CAR-T product, is the first FDA-approved gene therapy product on the market. It is currently approved in 2 indications, both pediatric and young adult relapse refractory ALL, as well as adult relapse refractory large B-cell lymphoma. It's been extensively studied in clinical trials, both for validated clinical outcomes as well as PRO data, as was previously presented by my colleague, Dr. Alia Farousi. It also continues to be studied in the commercial setting under a risk evaluation and mitigation strategy. As is previously discussed, chimeric antigen receptor therapies essentially are a living drug which allows the patient's tumor to be targeted by the patient's own immune system through a process of gene modification. This is a complex process that requires that the patient's own immune cells be removed, gene modified, and returned to the patient in a setting which has a degree of complexity that means that the timeline must be observed due to the significant burden of illness of these patients. Novartis has chosen to study a population of patients who have significant burden of illness. Although pediatric ALL is not a common condition, it is the most common cancer of childhood, and relapse and refractory ALL represents the most common cause of childhood cancer death, falling only behind accidental injuries and inflicted injuries. Whereas diffuse large B-cell lymphoma is a more common illness and one that is more likely to affect the Medicare population. In both cases, when the disease is relapsed and refractory, there are incredibly limited treatment options. And these usually require incredibly toxic therapies that, in order to reach standard of care with even acceptable outcomes, requires the use of a stem cell transplant. In the Juliet trial, where we treated patients with diffuse large B-cell lymphoma, you can see that approximately a quarter of our patients were over the age of 65, and these patients were heavily pretreated, with more than half of them having received 3 or more prior chemotherapies and having been refractory or relapsed to those therapies, and almost half of these patients having already received the standard of care therapy of autologous stem cell transplant. Unlike the data that's previously been shown regarding complete responses as low as 7%, the Juliet trial had a best overall response of 52%, with a complete response rate of 40%. This is nearly unheard of in this population. And when we look across subgroups again, you can see that the patients aged 65 or older had a 59% overall response rate, consistent across all subgroups with the overall response in our trials. But more importantly is not just the response, but the ability of these responses to be sustained. And you can see that in patients who were complete responders, there was a 95% overall survival at 1 year, and 78.5% of patients were relapse-free during this time point. In addition, because of the living nature of this drug, patients' response is not determined by their initial response, but in fact, 54% of patients will progress from a partial response to a complete response over timeframes as long as 9 to 12 months. These are not benign therapies, and certainly we acknowledge the adverse events that need to be followed. Here in the Juliet trial, you can see the adverse events greater than at grade 3 or higher included 23% of patients with CRS and 18% of patients with neurological toxicity. We also evaluated toxicities such as infection and longer-term toxicities such as hypogammaglobulinemia. It is important to understand that Novartis too has begun collaboration with the CIBMTR in order to provide a registry which will follow 2,500 patients, including at least 1,500 patients with diffuse large B-cell lymphoma for 15 years after their therapy. This is in accordance with the FDA guidelines and includes an incredibly robust amount of information, including patient-level characteristics as well as disease characteristics, and the efficacy and short and long-term safety information that can be followed for these patients. By partnering with the CIBMTR, we choose a leader in registry data for cell therapy, and one that all of our sites are familiar with. By doing so, we believe this will encourage early and robust use of this registry data and encourage and ensure that the real-world data that's collected really reflects the patient population who is being treated with Kymriah. In addition to this, by partnering with the CIBMTR, the data is not only owned by Novartis, but in fact belongs in the purview of CIBMTR, allowing access to that data and the analysis sets that can be considered to be done by CIBMTR and their research networks, as well as Novartis and health authorities. As a clinician, not far out from being part of the care provided to patients who would be receiving Kymriah, the importance of treating patients and including them in the decisions about their care is not lost on me. But Novartis does encourage CMS to leverage the existing data as well as the robust mechanisms for further data collection in order to make decisions about how best to approach payment decisions. Thank you.
Thank you, Dr. Abakoff. The next speaker is Dr. Marav Bar, an assistant member of the Fred Hutchinson Cancer Research Center.
Don't see anything here. See him? Okay. I'm Marav Bar. I'm assistant member at the Fred Hutch in Seattle, and I'm a transplanter, and I'm also taking care of patients after CAR T-cell therapy, and I'm also part of the long-term follow-up team for patients after transplant, and we are now building also our long-term follow-up for patients after receiving CAR T-cell therapy. And today, I mainly focus on question number 4 regarding timing of evaluation of PROS in patients after CAR T-cell therapy, and mainly for the long-term follow-up of those patients. My disclosure. There are objectives of a long-term follow-up after CAR T cells, which are to identify and mitigate the long-term risks of patients that are receiving those treatments and capture delayed adverse events. There are several challenges in long-term follow-up of patients after CAR T cell therapy. Most of them are the heterogeneous patient populations, the variety of the construct of the CAR T cells product. Although currently the two approved products and also most of the products that are under investigation target the CD19, in the future we will see more products with different targets that will affect the toxicity and the safety product of those products. There is a transition of care of the patient. Most of the patients come to big centers in order to get the CAR T cell therapy. However, after a short period of time, of a month or two, they return back to the referring physician. So it is a challenge to follow them for the long term. Although the very good responses that have been reported with the CAR T cell product, there is still relatively high rate of relapse of those patients, and therefore the patients are subsequently exposed to other treatments which will affect how the patients are feeling, their quality of life, and side effects that we will see in the long term. And additionally, patients have multiple comorbidities that will affect the PROS. And there are also specific challenges when we are talking in long-term quality of life and pro-assessment after CAR T cells. So, for example, there is no validated instruments for quality of life, and we see that there are different options that can be used. There is lack of uniformity between centers. So, although there are a number of centers that incorporating PROS into evaluation of patients after CAR T cell, there is no uniformity. And also, we don't know what optimal study design is. In addition, and other people here also reported about the significant resources that are indicated. So we need the resource in order to build the questionnaire into electronic forms, the follow-up with patients after they leaving the center back to the referring physician, and we'll need a lot of resources in order to collect the data and then to analyze the data. In our institution, we right now starting a pilot study to evaluate a patient after CAR T cells, and the objective is mainly feasibility, and we are using mainly the PROMISE Global Health and PROMISE 29, which have been validated in the transplant setting. And currently, as I said, there is a variability between center, and there are only a small number of studies that are currently ongoing. And we support collaborative work group in order to provide recommendations for instruments to be used, unified the study design, harmonization of the data, and potentially define a multi-center study between institutions. So currently, we think that effort should be made in order to incorporate the PROS in CAR T cell studies. However, we don't feel that PROS should be mandated for payer reimbursement for CAR T cell therapies.
Great. Thank you, Dr. Barr. Just before I want to confirm that Dr. Heather Jim is not in the audience, that she wasn't able to get here in time. Great. Okay, so our last speaker will be Dr. Gunjan Shah, hematologic oncologist at Sloan Kettering, who's representing the American Society for Blood and Marrow Transplantation.
Hi, everyone. Thank you for allowing me to speak with the committee. I am a bone marrow transplant physician and also work on cellular therapies, as well as part of the health reported outcomes program at MSK. And I am receiving travel funds today and speak on behalf of our program as well as the ASBMT. So you've heard a lot today over the last several hours about what patient-reported outcomes are and the differences of the different scales, and we agree with a lot of the comments already presented. What I'd like to do with my time today is present to you how we have used several different scales and changed over time and incorporated them into different trials, as well as how we are converting these into a standard of care approach across our entire service, as well as for the CAR T-cell patients. In terms of how to capture these by paper surveys and our conversion to an electronic process, and whether we're going to use them for research and clinical care and how that works. So I present this today just as a review article that was done in transplant looking at 114 studies, and you've learned today along the way of how many different patient-reported outcomes measures there are and why they can be used in different ways, and how they too tend to cluster around certain symptoms and certain assessments that can be used at different times. On the upper right, you can see a picture of sort of the different subscales of the Modality that are disease-based. And what we've used over the last 5 to 10 years in many of the transplant trials, specifically the autologous transplant trials, has been the Modality myeloma scale. And what we've been able to do in that, and the reason we use it, is it's been able to be done at several time points through the first 30 days. And you've seen today that there are differences in kind of the scale of early toxicities and sort of later recovery. And what we've done is been able to look at changes over time using an area under the curve method. And so being able to condense a lot of that information into one data point that can be compared, especially in intervention studies where you're really trying to affect the symptom burden as opposed to just collecting some of this information. On the bottom right, you've seen this already today, is the Puros CTCAE. And we've incorporated this into more recent trials and used the symptom bank in a way to actually incorporate similar questions to the Modality to see if patients really answered the questions the same way. We also, in our long-term maintenance trials and microbiota trials, have specifically taken out the questions that are related to diarrhea and constipation and sort of GI symptoms and been able to correlate those with the collected stool samples. On the upper right, upper left, you see the PROMIS score that's also been described many times today. And the reason I present this here is that we are in the process of converting from the Modality over to the PROMIS scale to better be generalizable across centers. And as you've seen, the plans from the CIBMTR and several other centers that have presented today. And so in an effort to be able to combine data, we are switching over to this scale. The bottom left, you can see sort of what the paper version of a server looks like, and sort of the scale system of this of being a 5-point scale versus some others being 10-point scales. Our informatics colleagues and surgical colleagues using a grant from PCORI have converted the MSK system from a paper format to what they call MSK Engaged, or an online system for collecting some of this information. And we're going to adopt this over to the transplant service and cellular therapies. On the left side, you can sort of see a particular patient's symptoms over time, and this is going to be available in the clinic, that you can look at a particular patient, convert it into their electronic record, and sort of follow them over time for a particular patient. Partly this is important because we are, and our institution has determined that it is important to act in some way on these information in real time, and so you can set criteria of if you are above a particular score that they will send a message both to the patient to call the office, but also to the office practice nurse to call the patient and determine if further things need to be done about it. On the right side, you can kind of see information sort of that was presented by other colleagues today of how do we present that information and what do we do with it in terms of both a research and clinical following over time. And so we have software where you can aggregate this data across trials, across patients, and present data in a very interesting way to be able to look at both intervention trials as well as just following over time. And so we're going to be incorporating all of this into our proposed new plan going forward. And so we know in the CAR T-cell space that patient-reported outcomes are still in development and too early to mandate in terms of coverage. However, we do agree that these are important to capture and study in both the clinical trial and commercial setting, which is what we are embarking on as well now, that we are going to use the PROMIS scale, PROMIS 29, and do weekly assessments and follow that with monthly assessments for the first year using our electronic system and be able to capture whether this is partly feasible and partly their scale over time. One of the interesting things in this, and part of the discussion in our switching from Medasi to Promise, was the time frame of all of this, that the Medasi scale was in a 24-hour recall period versus the 1-week recall period of the Promise scale. There are sort of pluses and minuses, obviously, on both sides of this, but one of the things that we think that some of the missing data can probably be accounted for by having this every 7-day scale, that there are those days where you were in the ICU where you weren't able to answer some of the questionnaires on a sort of every 24-hour scale, but over the last week be able to aggregate some of that data and potentially account for less missing data because of that. The other sort of further along questions that have been asked by the committee in terms of timing and feasibility, we do agree that the 3 to 6 month window seems to be the most reasonable option because of the patients going back, as have been described by other people, and we do think that the use of technology can allow for more collections over time, and we look forward to working with CMS and the rest of the people who have discussed today about doing this over time. Thank you.
Thank you, Dr. Shah. That concludes our scheduled public comment period. We have had one individual sign up for the open public comment period. I've been told that they will have 1 minute at this front mic to make comments, and that is Mallory O'Connor. Please introduce yourself. And make sure to disclose your conflicts of interest.
Thank you. My name is Mallory O'Connor with the Biotechnology Innovation Organization. Bio is an industry trade association, so we do represent manufacturers of CAR T cell therapies. And I'll be very brief here today, but thank you for your time. The Biotechnology Innovation Organization appreciates the opportunity to provide comments to the Medcac during this meeting on the state of evidence for CAR T cell therapies. Bio is the world's largest trade association representing biotechnology companies, academic institutions, and state biotechnology centers and related organizations. We appreciate the committee's focus on developing better understanding of the patient experience and PROs in cancer clinical studies and care. Bio believes that patients must be involved in decision-making regarding their care, and that patients and patient advocacy organizations play a vital role throughout the drug development process, as they know what desired outcomes, risks, and other considerations are most appropriate for their disease states and the disease states that they serve. We believe in open stakeholder dialogue on PROs as an important and useful exercise across many therapy areas, but we have significant concerns around the use of PROs in governing coverage decisions, particularly for this new therapy area serving vulnerable Medicare beneficiaries. It is critical to ensure that Medicare patients are able to receive timely access to the highest standard of treatment for their health condition. We therefore urge Medcac and the agency to move forward cautiously in the NCA process and not to incorporate PROs into coverage determinations for CAR T. Bio's position is detailed further in our written comments submitted to Medcac in advance of this meeting and in response to the NCA. Thank you very much.
Great. Thank you very much. So that concludes the morning sessions with the formal presentations both the scheduled public comments and the open public comment period. We're running a half an hour ahead of schedule, which I was told is a good thing. That will allow people to get into the cafeteria before the CMS lunch rush. People are asked to return to this room in 60 minutes by 12:30. So you actually have 63 minutes to eat lunch. So, thank you.
Excuse me, when we come back from lunch, if all of the presenters could please sit in the very first row where it says reserved for the second half. Thank you.